Okay. Okay.
Don't know why it does that.
Yeah, I don't know. All right, those of you joining live, welcome. All right. Haley, how did you do?
92.
Thank you. Annalise? Nicole?
100.
Thank you. Nicole, do you have 2 and 3 for me?
I do. I have 2 and 3 for you.
It'll be page 182 and 183.
182. I have 1 wrong on 182,
Thank you.
and I have a 100 on chapter 3 with a question mark on number 5, but I'll ask you after class.
Okay, no worries. Candace?
That would be why as well. You're gonna have to turn off your device real quick. Your caster.
The road?
Yeah, I'm gonna recycle the roads on and off because it's defaulting as the laptop is the audio. It's not recognizing your microphone.
Unplug and plug it back in.
Should be black cable.
Oh, I don't remember which one. That was the. All right, guys, give us a second. Technical difficulties.
We need to get one of those old-timey style, please stand by technical difficulties.
Yeah. Okay, that was the whole, that's the HDMI.
Oh, the HDMI just got unplugged from that. Okay, we're good there.
Signal detected.
HDMI's plugged back in. There we go. All right.
Okay, testing. Hopefully you guys can hear me now. I feel like the Verizon guy. Can you hear me now? All right, I'm on. All right. David.
100.
Thank you. Ranisha. That's fine. Michaela. Jacob. Oriana. Julie. Elizabeth. Russell. Finley. Gabriella. Isabella. Medina. Okay.
You were exactly right about the number of people.
Isn't it funny?
I can't imagine why you were like,
Yeah.
right.
Yeah. Even when I pointed out, people still, yeah, I mean, there was no seats on the first day. So yeah, it's funny that happens, but it is very convenient to be able to, log in from home. All right. So we're going to do a very brief review of what you read in chapter 4, because I think chapter 4 is really overwhelming. It's not, how do I put this? It's not structured well for retention. Like you can read the words, but you're going to forget exactly what you read. So as a CNA, you don't need to know what organs are in which body systems and how they work. You don't need to know any of that. Those of you who go on for nursing, you will need to know those things. You actually will have to take several anatomy classes in order to learn all of that before you even get into your nursing program. But as a CNA, we're not responsible for that knowledge. What we're responsible for as CNAs is being able to recognize changes in your patient and report those changes and know what is normal for aging. Because our bodies change throughout the life cycle, right? You're not exactly the same now as you were when you were a baby. or a teenager. Our bodies change. And a lot of the aging changes are going to affect your patients in small ways that you probably aren't even going to think about. So that's what we're going to talk about now. Is we're going to go through each one of these body systems and talk about the changes of aging associated with these body systems and things that you might want to watch out for or take special care with. So the first one we're going to talk about is our master system. This is the nervous system. This controls everything else. This is your master circuit board. And it is made up of brain, spinal cords, nerves. Again, you don't need to know what makes up the system, but you do need to kind of know a little bit about what it does and what happens when it ages. So this one, because it's made up of the brain, the spinal cord, and all of the nerves, your senses are going to be affected with aging. So think about our senses: sight, smell, hearing, taste, and even feel are all going to be affected as these nerves age. So one of the examples I like to give for this to help you understand why things change is, let's say that I invented something. We'll say this pen, right? I invented this pen and I want to have it produced. So I go to a couple of factories and tour the factories. The first one I tour is brand new, state of the art, completely automated. Everything is just perfect. Gives me good quality pens and consistently, right? Because it's brand new, state of the art. Well, the second factory I visit is 80 years old. The bricks are crumbling. The gears are rusty. It doesn't work half the time. And the pens it produces, yeah, not so good, right? They're missing pieces. Which factory do you think that I want? The first one. Why? Because it works. It's consistent. It gives me good quality stuff, right? Well, your brain is a memory making factory. That's what it does. It makes memories. When it's new, state of the art, everything works perfect. And the memories it makes are good quality memories that are going to last a lifetime. But as that factory ages, things start to break. The gears get a little rusty. Things aren't working quite the way they used to. And as we age a little bit more, those issues become bigger and bigger because nobody's in there replacing all of those little components that make your memories. We're stuck with what we had 80 years ago. So this is why somebody, as they age, can remember shoes they wore to a piano recital when they were 12, but has no idea if they've had lunch. Because the factory that was making the lunch memory is just not working today. Not working right now. Not online. Just like that 80-year-old pen factory, right? It's not going to be consistent and it's not going to produce high quality memories. But that memory that same factory made when they were 12, that memory is sticking around a while because it was good, high quality memory made when the factory was new. Do you guys understand that? So when you're working with older individuals and they say, is it lunchtime yet? And you say, yeah, you just had lunch. Remember that their factory just isn't online today. It's normal. It's okay. Make sense? Okay, that's normal. Now, if they've known you and you've taken care of them and they know you, and then today they have no idea who you are, that's not normal. That's not normal. Okay. So short-term forgetfulness, that can be normal with aging because our factory has aged. Serious lapses in memory, that's not normal. Or confusion that's sudden. Aging is gradual. It takes a long time to age. Anything sudden is not because of aging. So that's a key for you to remember on the written test. If any question has a sudden change, it's not part of aging. It must be reported immediately. Make sense? Aging is never sudden. Okay, good. Some of the other things that you're going to see with the aging process is decreased coordination. This makes them more prone to falls. Where, how many of you guys have a throw rug in your house somewhere? Throw rug? Okay. Throw rugs, when you're young, they are not a problem to you at all, right? You don't even notice them really, other than the pop of color on the floor. But just that little bit. So let me illustrate here. So we have this table and we have this paper, and there is a little bit of a height difference there because the paper's laying on the table, right? So the paper's raised up just a little bit. This is hardly even noticeable, very, very small change. Rugs, also very small change. You can go from the flat surface onto the rug and your brain accommodates and you don't even recognize that that has happened. But that little bit of a change when you have decreased coordination can be a really big deal, a really big deal. And it can throw your balance off and leave you more susceptible to falls. So when we're working with older individuals, throw rugs are not a good idea. They also pose a tripping hazard, but it's the coordination thing that's really the problem, okay, because of the height difference. Slower reflexes, so if they do start to fall, they're going to have a harder time catching themselves. Memory impairment, we just talked about, and decreased concentration. This can be very frustrating for your patients because if you've got somebody who's used to doing something, like let's just pick on knitting. Okay, we've got an older lady. She's used to knitting. She's knit all of her adult life. This is how she relaxes. She sits in front of the TV and she knits. Well, as she gets up in years, she may find it more difficult to concentrate on knitting and TV and listening to somebody, or she might be dropping stitches. She might lose her count. And that could be very, very frustrating for her because I've done this my whole life. Why is this now a problem? And it's just a normal change of aging. Don't take that frustration personally. It's not on you. They're frustrated with their own circumstances. Okay? Be supportive, be encouraging. But this is why a lot of older people give up hobbies. And that's sad. It's very sad. If it's something that brought them enjoyment, having to give it up because they are having trouble concentrating, that's sad. That's another loss in their life. And they've already had so many losses. So do what you can to encourage them. Okay. Cardiac system. This is also called the cardiovascular system. This is the heart and all the blood vessels that feed the body with nutrients. Heart pumps, pushes out blood. That blood circulates through the systems, and then it comes back to the heart where it pumps again and circulates it around. You're going to have changes of aging here too. That system gets weaker. The heart just doesn't pump nearly as well. So you end up with decreased endurance. Patients that used to be able to walk to the dining room and back, no problem. Now they might need a walker, or might be better to take them in a wheelchair to conserve their energy, or, you know, there's some changes there because they just don't have that endurance that they used to have. Higher blood pressure is very, very common. Prolonged bleeding. So if they get a skin tear, they might bleed for hours where you would clot up in minutes. And that's because the platelets are old, just like every other part of the body. Fragile vein walls. Guys, these two things right here lead to a lot of injuries and a lot of bleeding injuries in the elderly. So we've got to be really, really gentle with them. Respiratory system. This kind of goes along with the cardiac system because the heart pumping blood isn't going to do any good unless there's some oxygen in that blood. So as we age, our lungs are less elastic. They don't expand as well. It's harder to get a deep breath in. our alveoli, or the little air sacs where the oxygen exchange takes place. They exchange oxygen for carbon dioxide. Like anything else that's getting older, it gets like a patina, right? So if you've ever had a brand new car, right? When you take it off the lot, it's bright, it's shiny, the chrome is all chromy, and the paint is all painty, and right, everything looks really good, doesn't it? But after a few years, the paint gets a little duller, the chrome isn't as shiny, right? It gets this like patina over it. Well, that's what happens to your alveoli too. Your air sacs are not as efficient as they were when you were young. So you're not going to exchange gases as easily. And this can lead to a lot of fatigue. Just, I don't want to, I'm tired. I'm not getting enough oxygen. I'm not getting rid of my carbon dioxide effectively. Less endurance, remember that kind of goes along with that cardiac issue. Shortness of breath, very common on any exertion. So getting somebody up and walking them to the bathroom, you're fine. But your patient's like, that's because they're not exchanging gases very well. Okay. So short trips, frequent breaks, watch them for too much exertion. They're not going to recover from exertion like you do. Anybody here ever run track or participate in, running? Okay. When you're young and you're running, when you're done running, you end up in a recovery position, right? And your hands on knees, and you're trying to slow down that breathing, trying to catch up and get that oxygen status reestablished. Well, as your patients, that same response, you know how you can't really have a conversation in that position, right? You got to recover a little bit first. Well, your patients, as they age, that's very common after exertion. So if you're trying to ask them a question and they're kind of bent over, they're not going to be able to answer you. And you know what that feels like. So give them a minute to be able to recover first. Okay. Good. Good.
As far as their breathing goes, should we be telling them in through the nose?
Sure, you can you can, but chances are, if this is age related, they already know how to handle it. Yeah, some are. But here's the thing. For you, and you have to understand, aging changes everything. So if you are having trouble catching your breath, I can tell you, in through the nose, out through the mouth, and whether you're stubborn or not, right, you will have an effect of that. As we age, though, every part of that system is aging. And even if they're breathing in through the nose, out through the mouth, it's probably not going to have much of an effect, because we got to wait for the body to catch up. So where things that we suggest for younger people, we're suggesting it because all of the body systems in the younger people are working well. Does that make sense? So your older individual, when you said they're stubborn, right? Yeah, the older individual, they may already know, hey, that doesn't work for me. I'm just going to ignore you and try to accommodate on my own. And that may be where the stubbornness is coming from, because they have the benefit of the knowledge that you don't have, right? We're going to talk a little bit about that, the mindset thing, in just a few minutes. I've got a whole lecture on energy conservation that I have to give you, but it's all about how we think. And you guys are probably going to be surprised at this. We'll get there. Okay. Endocrine system is affected by aging. This is probably one of the more visible ones that we see, that we're familiar with aging, because we have decreased hormone production, right? Younger people, more hormones. Older, your hormone production decreases. This isn't just sex hormones, guys. That's the one we tend to focus on. That's not what this really is about. Hormones control everything. They control your digestion. They control your sleep. They control your metabolism. They control your hot and cold tolerance. They control every system in your body that runs on autopilot is controlled by a hormone. And now your hormones are affected. They're not as efficient. So if we keep that in mind, the symptoms kind of go along with this, right? We have decreased hormone production, which is going to lead to sleep disruptions. It's going to lead to a decrease in bone density. So one of the things that most people don't know is your heart relies on calcium to beat. You have to have calcium in the bloodstream in order for your cardiac cells to contract. So if you don't have as much calcium floating around your bloodstream, your hormones are going to be directed to go mine some calcium. And we actually have calcium mines right on board. There are bones in our teeth. So if we don't have enough calcium in our bloodstream for our cardiac muscles to contract, your body will go get some from the bones. It mines the bones. Now, over time, this is actually going to cause something called osteopenia or osteoporosis. It just means that you didn't have enough calcium throughout your lifetime. We kept taking from the bones, and now they look like Swiss cheese. So if this patient falls, what's likely to happen if they have Swiss cheese bones? They're going to break. Absolutely. Absolutely. And all of that is going to be affected by your endocrine system because those are the workers. Okay. Does that make sense? Now, there's a whole lot more that's overly simplified. Okay. There's a lot more in that cascade, but it's good for you to understand that we don't want our patients to fall because we, for the most part, probably don't know how dense their bones actually are. And we're not going to know until they fall and they break something. And then it's like, oh yeah, your bones are brittle. Well, thanks. That's a lot of help now, isn't it? So we want to try to protect our patients from falling whenever possible because you falling, you'll bounce. You'll be okay. Your patient falling could be a lifetime changing event. Does that make sense? Good. Now, what makes this even worse is that a lot of people don't really think about this, right? If you fall and you break something, let's just say you break your arm. You go to the hospital, you get your arm set in a cast. 6 weeks later, they take the cast off. You go through a little physical therapy and you're right as rain. I mean, you have really no long-term effects of that other than it might ache once in a while or something like that. But your function is pretty good. That's not the case when you're older. When you're older and you break something, the mechanism to knit that bone back together is affected. It doesn't work as well. So yeah, you can break your arm, we can put a cast on it, but instead of 6 weeks, it might be a couple of months because it's going to be slower healing of that bone, trying to knit it back together. And chances are it's never going to knit completely back together because we simply don't have the ingredients to do that anymore. But what really makes this bad is when it happens down here. Okay, arm is one thing, but when it happens to your hip or your leg, which is the most common break in the elderly, we may not be able to heal that ever. So we've taken somebody who was walking and independent and ambulatory, they fall and break their hip, and now they're bedbound for the rest of their life. That's a big change. That's not merely a broken bone. If you get a broken bone, it's a quick trip to the ER and you don't really think about it. You get people to sign your cast, life is great. An older person that gets a broken bone, that is a life-changing event. And what ends up happening to a way bigger percentage than I am comfortable with is that they end up dying. It wasn't the broken bone that killed them. It was the inability to move well that killed them. Okay. Inactivity can kill people. It is that serious. This is why we can't use side rails, because if you put somebody in bed and put the side rails up, you've made them inactive. and making them inactive can actually cause complications that can kill them. Immobility is bad for the body. Okay. So we've really got to make sure that we understand that all of these things together are going to put our patients at a disadvantage. And we're going to take steps to really protect them as we're working with them. Urinary system is affected. This is the one you're going to see the most. This affects you as a caregiver. How many times do you guys think you go to the bathroom a day? Yeah, probably 4 to 6 times a day, right? Maybe a little more, maybe a little less. It depends, right? But if you're working an 8-hour shift, you probably go to the bathroom once during that 8-hour shift. That's pretty common. You guys are young. Your bladders are still in good shape. As you age, bladders lose elasticity. They don't hold urine the same way they used to. So your older patients are going to need to go to the bathroom much more frequently than you do. Much more frequently. And this is a huge source of frustration for CNAs because, oh my gosh, I just took you. I just took you. But your patients, their bladders don't hold the way they used to. But even worse than that, if you came in here and I told you, okay, guys, I'm so sorry, but our bathroom's out of order today. You're just going to have to hold it till the end of class. You guys could probably do that. Even if you had to go, you could probably hold it. If you had to, right? You can hold that urine until the next exit when you're driving, right? You are able to delay urination once your brain signals, I got to pee. That's normal when you're young. You can delay it. You can push it off. And some of you have even forgotten to go to the bathroom until a little while later. And you're like, oh my gosh, I had to go pee. Let me go, right? Because you get distracted. That does not happen when you're older. When you are older, that delay of urination goes away. So when your patient says, I got to pee, they mean now, not 5 minutes from now, not a half hour from now. They mean now. So we end up with a situation that your patient has to pee more frequently and there's no lead time. So let's go back to our patient in our bed. We put the side rails up and the patient has to pee. And they hit the call light and they wait and they wait and they wait. Nobody comes. Nobody answers that call light. They don't have the luxury of time. They know that if they don't get to the bathroom in like the next 2 minutes, it's game over. Do you think they're going to lay there and wait for you? No. And this is what makes side rails so dangerous, because you are going to be busy taking care of all the patients that you're taking care of, and you may not be able to get to this one as quickly as the patient would like. Now the patient has to make a decision. The problem is that CNAs walk in and they see the patient coming back from the bathroom and they start to lecture the patient. I told you not to get out of bed, that I would come and help. Because we're thinking with young brains. We know that we can delay urination. We're thinking with a young brain. That patient doesn't have a young body. Do you guys understand that you are coming at this from 2 totally different mindsets? You can delay urination for your own body because everything works. Your patient cannot. Assuming that your patient can set you up for conflict. Okay? So if you walk into a patient's room and they're coming out of the bathroom when you told them do not get up out of bed, yelling at them is going to do absolutely nothing, because the next time they have to pee and you're not around, you know what they're going to do? They're going to go. That's right. That's a dignity issue. Yelling at them is not going to stop them from going. What it's going to do is make you the enemy. And at that point, they probably are going to stop using the call light and they're just going to go on their own. Help isn't help if it doesn't help, right? A lot of this has to do with our approach and our attitude, but it also has to do with our mindset. We're thinking with young brains. It's all we've ever known. So it's my job to make you understand what it looks like to have an older body, because that's the brain they're thinking with. Okay, good? Make sense? All right. Well, let me go back one. Especially with older men, they may have difficulty starting and stopping their stream. And this has to do with muscle tone, right? Starting and stopping the stream. So it may take them a little bit of time. You know, that you get them to the bathroom, they're standing there and nothing's happening, and you're getting frustrated because, oh my gosh, let's go. And it's because their body is not cooperating. It doesn't work the way it used to. But we also get incomplete emptying on both sexes. Like the bladder just doesn't, like, you know when you're peeing and you kind of give that last push and get everything out, right? Yeah, it doesn't do that well anymore. That squeezing, that incomplete emptying leaves some urine in the bladder for later. So now we're filling up quicker, and this is why we have to go to the bathroom every hour or so. All right, skin. This is the most visible sign of aging. Most visible. We get wrinkles. We get age spots. We get gray hair. A most visible sign of aging. You can visibly see that somebody is older by looking at them. This is, and this is where I used to start this lecture, because because it's visible, this is where your awareness stops. As a young person, you see somebody is old, but you think that just happens on the outside of the body. You don't really think about all of those changes. Everything that you're seeing on the outside is happening to some organ on the inside too. So we see this and stop there. This is probably the least impactful. This is the most visible, but it impacts the patient the least. Now, we get thin skin. The skin dries out. Patients don't need to shower as often. Like you probably shower, once a day or every couple days, right, to get the oils and dirt off of your skin. As you age, your oil production decreases. You're not really outside doing a whole lot. So we don't shower as often when we get older. Plus, it takes a lot of energy to shower. So your patients might go to twice a week showering. And that's perfectly okay because it's not drying out the skin. Soap dries the skin. So when we're older and we have thinner, drier skin, we probably don't want to put soap on it as often. We probably want to make sure that we're lotioning everything really well to try to maintain that skin integrity. Because if skin gets too dry, it tears.
I did it to my mom the other day with
Yep.
and I've never seen anything like that in my life. It just slid off.
Right.
The whole thumb, and I've never seen a skin tear.
Yep.
And so I put it back on, and it did heal after like 2 months, right back on. But I've never seen anything like that in my life.
It's like working with wet tissue paper. It tears that easy.
I couldn't believe it.
Yep. So we have to be super, super gentle with our older patient's skin. We talked about brittle nails when we did hand and nail care. We talked about the decrease in subcutaneous fat that's going to affect their temperature perception. We visibly see changes in hair color, decreased hair production, and age spots. These are all visible signs of aging. But remember, this is what we see. It doesn't stop there. This is just the beginning. Just the beginning. Reproductive system is affected. Again, this is all driven predominantly by hormones, which are decreased. So there's a lot of symptoms here beyond reproduction. You get hot flashes and night sweats. You can get behavioral changes associated with hormonal fluctuations. You can get erectile dysfunction, decreased fertility. Now, female fertility is way more affected by age than male fertility. Male fertility is still affected, but not to the degree that female is. One of the things that's interesting for young people to understand, though, is that even though we have these hormone changes and changes in reproduction, older people can still lead very active sex lives, even in facilities. So we have to be aware of that sex drive is a biological drive. It is a need, and people will act on that. If you notice anything, report it to the nurse. Okay? It's not up to you to pass judgment. It's not cute. It's not disgusting. It's not any of the adjectives that you want to use. It is a behavior. Like any other behavior, you report it to the nurse, and the nurse's responsibility is to figure out whether it's appropriate or not and what we're going to do about it. As long as both parties are consenting adults and able to give consent, it's perfectly okay. If one party is unable to give consent and the other is, that is not appropriate. That's not a decision you can make. Okay? So the nurse needs to know. Good? All right, gastrointestinal. This gets affected in a pretty big way. What is your favorite food? Think about your favorite food. Give me some favorite foods. Mexican. Oh, that's a good one. Let's talk about Mexican food. As we age, Mexican food tends to be a bit spicy, right? A bit heavy. As we age, our digestion slows down. Our ability to digest heavily spiced foods can be affected. So if somebody really enjoyed Mexican food when they were younger and in their middle years, when they get older, Taco Tuesday may not be a thing for them. Okay. They may go, no, that just doesn't work for me. It's like lasagna. You may love lasagna when you're younger, or pizza, but when you get older, you just cannot tolerate that, that acid in the tomatoes. Or you may have somebody who absolutely loves Chinese food, but those have a lot of sauces. Americanized Chinese food has a lot of sauces and a lot of sodium, and that may actually affect their fluid retention. So the way they eat is actually going to change as they age. Now, we especially in America, we derive a lot of our joy and contentment in life from food. So imagine for a second, you're in a strange place against your will. Nobody's coming and visiting you. You feel isolated. You had to sell your home. You had to give away your pets. You've lost absolutely everything. And now you can't even enjoy your favorite foods. Do you think this is going to be a happy person? No. So we've got to take that into consideration. Okay? Be nice. Be nice. They are experiencing issues and losses that you haven't even been able to conceive of. So be nice. This is probably the most common thing you're going to see, though. The esophagus is the tube that goes from your mouth down to your stomach, and it's actually a muscle. It contracts to push food down. Food doesn't just fall down by gravity. It actually contracts. Well, like every other muscle, it's not going to work as well as we get older. So that means that stuff can get caught in the esophagus, and it can feel like there's a ball of food there. Now they're not going to be able to eat. So small bites. Small. I mean, half of what you think small is. Small bites. Frequent liquids to help wash things down. Softer foods. These are all accommodations that are probably going to have to be made as we're feeding or helping our older individuals eat. Constipation, very common. For some reason, once you get into your 60s, you become absolutely preoccupied with your bowel status. And you will tell everybody, your hairdresser, the clerk at the grocery store, You will tell everybody about your bowel status. Oh my gosh, I haven't been able to go in 3 days. I'm backed up. I feel horrible. Right? You are not shy. You are going to tell the world about your bowel status because constipation becomes a daily struggle. And that's because we're not processing foods the way we should. We're not absorbing the nutrients the way we should. We're not, one of our senses, which is diminished thirst, hunger and thirst, that's a sense, is not going to have us drinking enough. So our stool gets kind of hard and compacted. The movement of stool through the system is based on muscles. Well, we're not as active. So this becomes a daily battle, and your patients will not be shy about sharing. But we do that. This is why we log bowel movements on all of our patients to know where they're at. Okay. Musculoskeletal system, the muscles decrease in size and strength quite often as we age. It's very, very common. Decreased bone density. Inflammation of the joints. This is called arthritis, and it's very, very common as we age, and it's way more painful than I thought it was. When I was young and I would hear arthritis, I thought, take a cup of Advil, you're fine, right? I'm getting up there now, and I have arthritis in both of my knees, and let me tell you, I have had broken bones that hurt less than walking on a knee with arthritis. It is horrible. So don't mistake this, guys. Don't think that arthritis, inflammation of the joints, is some little scratch, boo-boo, no big deal. This can be debilitating. Seriously. Especially if it's going to rain, right? If the weather is changing, if it's cold. Your patient may be sitting in a chair and you're like, come on, let's get up and go to breakfast. They're like, nope, I can't walk today. They mean it. They're not kidding. If the joint isn't working, it's not working. And no amount of a young person telling it to work is going to help. If that were the case, if young people could come along and tell an old person how to do stuff and it actually worked, young people would fix society, all of medical and society. It doesn't work like that. Okay. Good. All right. Lymphatic system is also affected. This is probably the least understood system in the body. Most people don't really understand what the lymph system is and what it does, but it's very, very important in immune function. It's our recycling center. It pulls out all of the excess fluid from places it shouldn't be. It cleans it and then puts it back in circulation. It's a very, very important system of the body, but it's not well understood. It is going to be affected, which means that we're probably going to have fluid hanging out in places that fluid doesn't belong, and we're not going to be able to get it back into circulation. So movement of your patient is important. Immobility can end up with swelling in places that we don't ever get it out of. We don't ever get it out of. When you have a sponge, a kitchen sponge, and you get water in that kitchen sponge, the water goes in each of those little individual cells. The only way to get the water out of a sponge is to totally squeeze it. But even still, it's not completely dry, is it? There's still water in some of those cells that you just can't quite get to. That's what happens when our lymph system isn't working well. Fluid gets into places it shouldn't be, and nothing we do is going to get it out of those places. It's now stuck there. Thank you. This is why mobility is super important. We don't want our patients sitting around, even though their knees hurt. We don't want them sitting around, not doing anything, because it's going to affect their digestion and their cardiac system and their respiratory system and their coordination and all of that. So if our patient is telling us, I can't walk because my knee hurts, who should we tell that information to? The nurse, because the nurse has some magic pills that they can give the patient that takes some of that pain away. We can get that patient up walking, and now we've avoided some pretty serious problems later down the road. Good. Everything we know, the nurse should know. Normal or not, everything we know, the nurse should know. Good. All right. Any questions on the body systems? Okay. So a quick review of the skills that we've learned so far. A pulse is a measurement of how many times the heart has beat over 1 minute. Radial pulse is located at the top of the thumb side of the wrist, way up at the top. You're going to use 2 fingers, fingertips, not flat part. Find the pulse, put your thumb on the back, and count for 1 full minute. If the care plan doesn't tell us to count for 1 full minute, we can do 15 seconds and multiply that by 4, but your reading is over 1 full minute. Normal is between 60 and 100. We learned how to dress a resident with a weak arm, and the way we remember this is USA first. You want to ask them what they want to wear. You're going to gather the clothing before you undress them so they're not laying there naked waiting on you. You're going to make sure they're always covered by something. So we're going to use a privacy blanket for this. We'll lift from below with a flat palm and support all joints as we lift them. We undress the strong arm first, dress the weak arm first, and make sure everything looks good before we leave. Okay. We learned how to do hand and nail care. This is a mini mani. You're going to soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, file the rough edges, and put some lotion on. Washing rules are going to apply here. We're going to check the water. We're going to let them check the water. Don't put soap in the water so we have it for rinsing. Support the arm as we move it. And make sure it's always resting on something soft, just like because the skin is so tissue thin. Okay. We learn how to make an occupied bed. Remember, the patient should never be on a bare mattress. Clean rolls toward me, dirty rolls away. That's how we change that bottom sheet. And it keeps the patient from laying on a bare mattress, but it also keeps the dirty sheet from contaminating the top surface of the clean sheet. For this skill, make sure that all 4 corners are on the mattress really well. Put the top sheet on, make hospital corners, or at least get the corners underneath the mattress, and then change the pillowcase last so you limit the amount of time the patient doesn't have a pillow under their head. All right, so any questions so far? Okay. We're going to learn how to turn a patient over onto their side now. So this is side lying position on page 138. So if you look at page 138, you can see our synopsis of the skill here. All of the principles that are involved, they're all spelled out for us here. Our skill-specific steps, I've got a video, and this is information on timing, who this is going to be done on, and where they're going to be. But if you look here, there's nothing new to learn. We know to follow the care plan. We know to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to turn you on your side. Is that okay? Close curtain, wash hands, get supplies. We're going to evaluate if we need gloves. If I'm going to be touching body fluids, personal skin, or non-intact skin, I need gloves. We need a barrier to put our supplies on. One of the supplies I'm going to need is a privacy blanket because your patient needs to be covered at all times, either with a sheet or the blanket. Linen rules are going to apply. For this skill, I'm going to need 3 pillows, and I don't want to hold those pillows up next to my uniform. So I'm going to get the pillows and put them on the barrier without holding them right against me. Patient should always be in the middle of the bed, and we turn the patient away from us. We learned that last class, and then our closing is always the same. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. I'm going to open the curtain. Environment's clean. Bed's in the low position. I'm going to go wash my hands. That's the skill. What we have to learn now, we know all of those things. What we have to learn now are things related to the actual skill itself, the skill-specific steps. So if you look on page 139, at the top, you have your care plan. This tells us what to do. We're going to take a look at that in a minute. And at the bottom, you have your supplies. In between, you've got step-by-step instructions that tell you exactly how to do this skill. Here's our care plan. It says position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So this patient can't turn on their own. Does not say they're immobile. Does not say they're paralyzed. It does not say they cannot move. It just says they cannot turn. Be careful about changing this care plan in your mind. Okay. So let's take a look at the steps that we need to learn to do this particular skill. Remember that we can't use side rails to keep our patients safe. They're just like a crib. So we're not going to use side rails for this skill. Instead, half rails aren't side rails. Instead, we're going to scoot that patient toward us so that after we roll them, they're in the middle of the bed. This is scoot and roll. We talked a little bit about this last class. How we do that, though, there's a specific process that we're going to use to make it a little bit easier on us and them. Before I show you that process, though, I do want to talk about immobile patients. Even though this patient isn't immobile, it's kind of what most people think about. If we're going to turn somebody, it must mean they can't move on their own. Let's talk a little bit about immobility. If somebody cannot move on their own, they're paralyzed or they had a stroke or whatever the case, advanced dementia, and they do not move on their own, that means that everything is going to have to be done for them. Absolutely everything. They're going to have to be fed and bathed and dressed and toileted and mouth care, and everything is going to be done for them. Somebody that is immobile. It also means they're not getting out of bed and going to the bathroom. If they can't move, that means that they're probably going to be incontinent. So we're going to talk about how to work with incontinent patients next week, next Wednesday. But I want you just to tuck that information in the back of your mind. Somebody that can't get out of bed has to have everything done for them. Because of this, because they're immobile, every one of those body systems that we just talked about is going to be affected. The bone, because their nutrition isn't going to be real well, they're probably not getting enough calcium, which means that they're mining calcium from their bones. So their bone density is going to decrease. Their muscles are going to shrink. It's called atrophy. They get weaker. Their digestion is going to slow way down because we actually rely on muscle movement in our abdominal muscles to move food through our small intestines. If you're not moving, that food just kind of sits there. So now we're at risk of constipation. Our lungs aren't going to inflate as well because we're laying down. It's now having to fight gravity. We're not going to inflate our lungs as well, which means that our oxygen levels are probably going to be a little bit lower. We're probably not going to get rid of all of our carbon dioxide, which can cause a little confusion. You're starting to see that this is not good. There is no good news here at all. It's going to affect every single part of your patient, everything. So immobility is not good. It's not good for the patient in any way at all. This is why, even when your patient is immobile, we often use mechanical lifts or things like that to get them out of bed and sitting in the bedside chair or get them into a wheelchair or get them moving in some way. We don't just park them in a bed and leave them there forever. But one of the most affected organs with immobility is the skin. When you have somebody that's not moving, their skin gets affected in a pretty big way. And it doesn't take long for this to happen. So I want you to think about you at night in bed. When you go to bed, you toss and you turn all night long. You don't stay in the same position. You're constantly moving. The reason that you're moving is because of blood flow, circulation. On Earth, we have gravity. Gravity pulls everything down. So whatever surface is pressing down, if you're a tummy sleeper, right, you're sleeping on your tummy, that means that your whole body weight is being pulled down through your tummy. If you're sleeping on your back, your whole body weight is being pulled down through your back. Side, same thing. Well, what that does, your whole body weight, guys, is pressing down. What that does is those blood vessels get all squished. And now we don't have blood flow to that area. Now, the muscles in that area go, excuse me, brain, we're starving here. Need a little blood flow, please. And your brain tells your body, okay, flip. And you do. And that opens up those blood vessels, allows blood back into that area. Now, this is also happening when you're sitting in these chairs. Right? You don't notice it at night because you're asleep. You toss and turn. But in these chairs, you guys are not sitting still. You're constantly moving, shifting, changing position. It's for the same reason, blood flow. But let me give you a little experiment to show you just how quickly we can go sideways here, okay? How quickly this can get off track. What I want you to do is take one of your hands and put it underneath your leg. I want you to sit on one of your hands for the next 2 minutes. Please play along. Sit on one of your hands for the next 2 minutes. It's going to seem like a long time. Trust me, it's going to seem like a long time. I'll let you know when to take your hand out. I will not forget. I have a slide to remind me. Okay, just stay on your hand for a few minutes. So as we are laying down, particularly on our back, anywhere where a bone is pressing down is going to be what we call a pressure point. This is the back of your head, your shoulders, your elbows, your hips, the back of your thighs, back of your calves, and your heel. These are pressure points. If we have a pressure point where bone is pressing down, the muscle and the blood vessels in between are getting squished. Now, when that happens, when you've got bones pressing down and all of these layers start to get squished, blood flow stops to those areas. Now, that's bad. We need blood flow. We need blood flow. So, as the bone and other weight is pressing down and we squish up all of these layers, including our blood vessels, we're having pressure down from the top. But we also end up with pressure pushing up from the bottom if we have any wrinkles or anything the patient is laying on. Even something like a crumb will press up into the skin. Okay? So we have bone, muscle, fat, pressure down, and then whatever you're laying on is going to press up. And what's caught right in the middle are your blood vessels. So as those blood vessels get squished, if you don't do anything about that, that tissue around those blood vessels doesn't get any blood flow, and it will eventually die. It doesn't take long for this to happen. Go ahead and take your hand out. I want you to look at your hand very closely. Do you have any color changes on your hand? Anybody see a color change? Okay. Look super close, super close. Can you see the pattern of the chair? Can you see the pattern? Okay. When something is pressing up, okay, like wrinkles, the chair, your clothing, when something presses into the skin, it's going to cut it from the outside in. And this only takes as little as 20 minutes to happen in the right conditions. If you have red areas or paleness on your skin, 2 minutes, you had a skin change. Now imagine if we didn't move for 2 hours. Those lines would get deeper and deeper and deeper and deeper, and they're eventually going to cut into the skin. And we call this a pressure sore. So in general, if your patient cannot move on their own, like you wanted to pull your hand out when it got uncomfortable, you would have shifted your weight if I didn't tell you to sit still and hold your hand there. you would have automatically relieved that pressure. But what if you can't? Then we get into dangerous territory here. Does that make sense? Okay. So when we're working with patients who are immobile and they can't change their position, we need to be aware that anything that's under them pressing into the skin is a danger. So we want to minimize wrinkles, make sure there's no crumbs, make sure they're not laying on their remote control or cell phone charger or anything like that. You also want to make sure that we change the patient's position often to relieve those areas of pressure. So in 2 minutes, you got changes. Imagine 2 hours. A lot of CNAs take a wrong turn here and they think they're doing a favor. They think they're doing a good job. When you have an immobile patient, you have to change their position every 2 hours around the clock, every 2 hours around the clock, at 2 a.m., at 4 a.m., at 6 a.m., at 8 a.m. We are waking them up and turning them over. And a lot of CNAs feel really bad about that. They don't want to wake that patient up again. They want the patient to sleep through the night. The problem is that if you do that, that patient's muscles, skin, tendons, blood vessels have not had any blood flow for that whole time. And those areas are going to die and your patient is going to get a pressure sore. There's no way around it. This is how pressure sores happen, and they happen often. So don't let your patient sleep through the night thinking you're doing them a favor. Because pressure sores are, imagine the very worst injury you've ever had and multiply that by 100 and then make it last about 2 years. That's a pressure sore. I have seen pressure sores that happened overnight that went all the way to the bone. On the back, the lower back, the tailbone area, all the way to the bone. So you turn the patient over and you're looking at white bone. That's horrible. We can do better than that. Did it? Isn't it horrible? Horrible. We control this. This is 100% in our control. Pressure sores don't just happen. They don't.
That's a pressure sore. Like this.
No, that's a skin tear.
Okay.
That's a skin tear. Pressure sore is prolonged immobility, interrupting the blood flow to an area. Okay, good. So turning a patient every 2 hours around the clock is super, super important. And this is what your care plan is going to tell you to do if you have an immobile patient. Now, some patients may even need to be turned more often than this. Your care plan will indicate that. But in general, it's every 2 hours around the clock. So this means your patient's going to start on their back. They're going to go to their right side. 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back, right, back, left, right, back, left, back. And a lot of times we use something like this called a turning clock. And this can go right on the wall over the patient's bed, keeps everybody on the same page. So I know if I walk in at 10:05 in the morning, right? So this is my AM clock. At 10:05 in the morning, my patient should be on their back. So if I walk in the room and my patient is not on their back, I know that this has not been done. Good? If your patient can move themselves, they will, right? An immobile patient is somebody who can't move themselves.
You said that some of them aren't immobile, but they just have a hard time moving themselves.
So let's talk about this lady, right? She just had abdominal surgery. We cut her open from here to here, all the way open. She's got these butterfly bandages that's just holding her close. Well, she can't flip onto her side because all of her abdominal muscles have just been cut, right? So she can't roll onto her side. She can move around in bed. She can scoot, but she's not going to be able to roll on her own, right? So your care plan would probably tell you to assist your patient by turning them on their side. Doesn't mean the patient's immobile. It just means that they can't, for whatever reason, turn on their own. Remember that there's a million different options for patients. Everybody's going to be a little bit different. Okay. So we're going to follow the care plan for that patient. All right. Your patient must always be in the middle of the bed. Let me go ahead and pull up a chair here. Speaking of knee pain. Thank you. So your patient must always be in the middle of the bed, no matter what. If they're on their back, they should be in the middle of the bed on their back. If they're on their side, they should be in the middle of the bed after you've turned them onto their side. Patients have to be in the middle of the bed. Now, if I just walk over to this patient and turn her on her side, she's not going to be in the middle of the bed. She's going to be too close to the edge, and that could cause her to fall. But it could also cause her some psychological distress. If you are laying too close to the edge of the bed, you are constantly on edge that you're going to fall. And that can cause psychological distress. Is that patient going to be able to rest? No. So middle of the bed. Okay. That could be a test question. What's that?
I said I had a wife, kids, and animals.
Yeah, you're always on the edge. All right. So especially when your patient is on their side, they cannot be near the edge of the bed. So in order to prevent that from happening, we simply scoot them toward us, and then we're going to roll them away from us. Now, if they can roll and we're just helping, that's easy. That's easy. Scoot them towards you and then help them roll. That's easy. But what if they can't roll on their own? Let's go back to that lady that just had abdominal surgery. She can't roll on her own. Like, her abdominal muscles are not even speaking to each other at this point. And you have to have abdominal muscles to flip yourself over. So they're not even speaking. They're divorced. They're, you know, it's not a good time in their household right now. So they need some help. So if I just walk up, scoot the patient toward me, and then try to push her over on her side, that's going to be a lot of effort on my part. And it's probably going to make her very, very uncomfortable because of the way that I'm manipulating her body. There is a better way to do this. And it's all about proper preparation. So if we scoot the patient toward us, and then we're going to get ready to roll them onto their side, we're going to prepare their extremities for the roll before we roll them. And if you do this properly, you can turn somebody 3 times your body weight with no stress on them or you. 3 times your body weight, easily. And you'll be amazed at just how easy it actually is. Now, if you just try to manhandle them onto their side, you can only handle somebody about your body size. But if you prepare them properly first, you can actually increase that to about 3 times your body size. Okay, I'm going to show you how to do that. Now, if the patient can't scoot towards you, for the test they can. Patient can scoot towards you. It just says they can't roll. If they can't scoot towards you, then you have to have a way of moving them in bed. So we can use a draw sheet, which is a flat sheet put underneath the patient between the shoulders and the thighs that we use as a sling. You just pick up the sheet, you pull it towards you, and voila, they're now closer to you. So a draw sheet can work really well. You can also use something called a slide sheet, which is a super slippery type material. They're very expensive. Not all facilities have them, but when you put it under the patient, it almost levitates the patient. So it makes it really easy for them to move. You can also move them in segments. We talked about that last class, but you can get them to the edge of the bed in whatever method the care plan tells you to. So if the patient is immobile, the draw sheet should already be on the bed, because we just generally put draw sheets on the bed for anybody that we know has mobility issues. It's part of making the bed. If we don't need the draw sheet, there's no need to put one there. So if your patient is in and out of bed on their own, we don't need a draw sheet. But this is all part of setting the room up for your patient. Okay. But if you have to put a draw sheet under, you would turn the patient over on, remember clean rolls toward me, dirty rolls away? So we're going to take the draw sheet, we're going to roll it toward us, turn the patient over, put the draw sheet there, bring them back over, go around to the other side and lay it out. And now we've got a draw sheet under them. Anything that has to go under the patient, whether it's a sheet, a draw sheet, a barrier, a chucks, whatever it is, we're going to use that method. Clean rolls toward me, dirty rolls away. This is how you position a patient to prepare for turning. Now, it depends on which side you're going to turn the patient to. That's this whole thing hinges on that. You have to know which way are you turning the patient. So if I'm going to turn the patient on their right side, her right side is over there. I'm going to turn her facing that wall. Okay. I'm going to turn her onto her right side. I'm going to turn her facing that wall. Remember, I always have to be behind the patient after the turn, right? So I'm going to stand on this side of the bed to turn her onto her right side. If I were to turn her on her left side, where would I need to be? On that side of the bed. So you have to know which way you're turning to know which side of the bed you need to be on to make this happen. But once you're on the correct side of the bed, the furthest arm away from you goes up. The closest arm crosses the chest. So if I'm over here, if I'm going to turn the patient onto their left, I'm over here, their left arm goes up, their right arm goes over. If I'm turning them on their right side and I'm over here, the right arm goes up, the left arm goes over. So furthest arm up, closest arm crosses. Good? Furthest arm up, closest arm crosses. Now we move on to the legs. The closest knee to me, I'm going to bend and put the foot flat on the bed. The furthest knee from me, I'm going to angle out. Because after the turn, I don't want those knees right on top of each other. So the closest knee gets bent up, foot flat on the bed. The furthest knee gets angled out. And you can kind of see that there. And then, now that we have them positioned, it's a very easy turn. One hand on the shoulder, one hand on the hip, and there's no force required. In fact, if you push too hard, you'll roll that patient right out of bed. No force is required because all of their weight is already distributed over to the side that you're turning them onto. Okay. So here's our care plan. We're going to position the resident on his left side. So if I'm going to put the patient on his left side, where do I need to be? On the right side of the bed. It tells us that patient requires support to remain on his side and is unable to assist with turning. So I can ask the patient to scoot. That's fine. Scoot toward me. I don't need a draw sheet. Don't need to move them in segments. Just scoot toward me. And then we're going to move the extremities to get them prepared for the turn. And then we'll turn them away from us. But it says they require support to remain on their side. So we're going to use some pillows for that. For this skill, I'm going to start with my opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to turn you on to your left side. Is that okay? Close curtain, wash hands. And then I'm going to go get a barrier. I'm going to decide if I need gloves. If my patient's incontinent, I need gloves. If my patient has an incision that I'm going to be near, I need gloves. If my patient is fully dressed, holding onto all of their body fluids like a champ, do I need gloves? No. So for the test, one of you guys is going to be the patient in the bed. You are going to be fully clothed. And I'm assuming you guys all hold on to all of your own body fluids like a champ. So during the test, you will not need gloves for this. Okay? In a clinical setting, you probably will. Depends on the circumstance. Good? Good? All right. We're going to get a barrier, put it on our table first, and then we're going to get 3 pillows and a privacy blanket. I do need a privacy blanket because I have to arrange the legs, put a pillow between the legs. I got to work down there. The sheet's going to be in my way. So if I put a privacy blanket on and take the sheet down, it gives me access to all of the extremities that I need to work with. And then at the end of the skill, I'll pull the sheet back up and take the privacy blanket away. But that way my patient isn't laying there exposed while I'm doing the skill. All right. Don't hold the pillows up next to your uniform. Your uniform is not clean. Remember that the patient must be in the center of the bed. We're going to position them for turning and make sure we turn them away from us and follow that care plan as to which side they need to be turned onto. You want to make sure that after the turn, they're in the middle of the bed. So this is where I want you to kind of stop during the skill. When you turn that patient over, I want you to stop and look. If that patient is too close to the edge of the bed, that evaluator saw it. I guarantee you that evaluator sees that. And if you don't fix it, if you don't correct it, if you don't make sure that patient's in the middle of the bed, you will fail. So when you turn this patient over, you need to stop and look. Are they in the middle of the bed? If not, turn them back onto their back, get them closer to you, and then turn them again. Do it as many times as you need to get that patient in the middle of the bed after the turn. Got it? Got it? Okay. After the turn, you want to make sure that those knees are not right on top of each other. You want to offset one of them a little bit. Just bring that top leg a little bit forward so those knees aren't pressing right on top of each other. If you've got somebody who is immobile, especially, that pressure of those two bones pressing together can cause a pressure sore between their legs at their knees, and it's very uncomfortable. So make sure that top leg is just a little offset. We're going to put a pillow behind their back in a roll, and this just helps keep their body from moving backwards because of gravity. Gravity is always going to pull them onto their back. It's just what gravity does. So if we put a pillow there in a roll, it keeps the body from coming back onto their back. I'm going to show you in the video how to do this. You tuck one edge of the pillow under the patient's back, roll it up, and just tuck the other edge under the patient's back. It should be a nice roll when you're done. That's the hard pillow. You need to practice that one. Once you do that, we'll come around to the other side of the bed, put a pillow in between their legs, specifically between the knees and the ankles. You don't want those bony areas, one on top of each other. And then you're going to put a pillow underneath the top arm. That gets that arm in a neutral position, relieves pressure from the neck and the head. And then you want to adjust the pillow under their head. That pillow, once you turn the patient, chances are their shoulder is going to be up on that pillow. That's going to scrunch that shoulder up. So we want to get that pillow out from underneath the shoulder and just make sure it's under the head and neck only, not the shoulder. So adjust that head pillow. Then, once you've done that, you're going to put the call light directly in their bottom hand. Not the top hand, the bottom hand, the one that's underneath the pillow. The reason for that is we do not want the call light cord, this cord, to stretch along their neck to go into that top hand, because that's a choking hazard. So this going into the bottom hand keeps the cord from being a danger to the patient. Good? Good? All right. Then we'll do our closing. Take call light or take the privacy blanket away. Make sure they have their call light. Ask if they're comfortable. Is there anything else I can get for you? Bed is in the low position. Environment is clean. Open the curtain. Read your care plan again. My skill is done. That's the skill. It gives us, I think it was like 14 minutes to do this skill. How long? 8, okay. It gives us 8 minutes to do this skill. I want you to remember that what you're turning a patient over, putting a pillow behind their back, between their legs, under their top arm, adjusting the one under their head. It doesn't take 8 minutes to do. Don't rush this skill. Make sure you're taking the time to make sure they're in the middle of the bed. That's the really important thing. Don't rush this. Okay? All right, Jake, do you want to put Sidelying position up for me, please? No sound. All right, let's go take a break. We're on break. I did.
It's not
Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to turn you onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I'll get clean supplies. We're going to start with a barrier, and we'll place it on the overbed table. And this gives us a clean place to put our clean supplies. Now I'll get 3 pillows. And a privacy blanket. We'll bring this over to the side of the bed. Okay, Mr. Jones, I'm going to start with a privacy blanket. I'll place this on top of you to help protect your privacy and to keep you warm while we do this skill. So I'll take the privacy blanket and unfold it, being careful not to snap it or shake it. We'll lay it right over the patient on top of the sheet. Can you hold that for me? Thank you. I'm going to pull the sheet all the way down to the end of the bed. This just gets that sheet out of our way. Okay, Mr. Jones, can you scoot your body toward me? Thank you. Now I'm going to position you for the turn. So we're going to take the furthest arm and place it up over the head. The closest arm will cross the chest. The closest knee is going to bend with the foot flat on the bed. And then the furthest knee will angle out. Okay, just relax for me. Thank you. And now I'm going to roll you on your side on the count of 3. 1, 2, 3. So I'll roll the patient, maintaining a wide base of support. And then I'll use some pillows to keep him in this position. So the first pillow will go behind the back. We're going to move the privacy blanket out of our way so we don't tuck it in. The first pillow will go behind the back. We're going to tuck this edge underneath the patient. So I'm going to tuck down and under. This edge will roll up and then under the patient, down and under. And that provides a nice roll. We'll go to the other side of the bed. So this pillow will go between the legs, specifically between the knees and the ankles. We don't want the legs to lay right on top of each other, so I'm going to move the top leg just a little bit forward, and then I'll lift from below and place the pillow in between the legs. That way they're not laying right on top of each other, and the bony prominences are separated by the pillow. We'll cover the patient up. I'm going to take the third pillow, and this one will go underneath this top arm. As the arm droops down, this puts a lot of pressure along the upper back and into the neck. We need that arm in a neutral position. So I'll take the pillow, lift the arm from below, and place the pillow right under the elbow area of that top arm. Now the pillow under the head is under the bottom shoulder. So we're going to lift the head up, move the pillow so that it's only supporting the head and neck, and then we'll place that bottom arm underneath the pillow. We're going to take the call light and place it directly in that bottom hand. Okay, Mr. Jones, I'm going to remove the blanket and pull the sheet up now. So we'll pull the sheet right up over the blanket and the pillows, and then remove that privacy blanket, rolling it into a ball as we remove it so that trailing edges don't contaminate other surfaces. We'll adjust the sheet for neatness and appearance. And we'll open the privacy curtain. Mr. Jones, are you comfortable?
Yes.
Okay, I'm going to go dispose of my linens and I'll be right back. This will go into dirty linen. We'll dispose of the barrier in the trash can. And we'll move the tray table back to storage. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Okay. Is the head of the bed, does it need to be adjusted at all?
No, thank you.
Your environment is clean. Bed is in the low position. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Oh. All right. Any questions? Any questions? All right, that's one that I make look easy. You're going to have to practice that one.
What if the patient finds the position for them uncomfortable?
Do your best to make them comfortable. You know, reposition as much as you can, reposition the pillows, shift their hips, their legs, whatever the case may be, and then report it to the nurse. Okay. If they insist on, you know, going back onto their back or whatever position, again, report that to the nurse. It's not a CNA's, bless you, it's not a CNA's job to educate the patient on why they need to be turned, you know, the whole blood flow, circulation, that type of thing. That's not really our job as a CNA. It's our job to report that to the nurse and then let the nurse educate the patient on why, you know, repositioning is important.
I'm not sure how much to talk it out while I'm doing the skill during the test.
Okay, that's a great question, and that comes up quite a bit. Do I have to say everything you say during the test? And the answer is no. You don't have to say everything that I say during the test, but there are some benefits to talking it out. First is that evaluator is going to be paying attention to the checklist, and they may not be looking directly at you as you're doing these steps. So there's a possibility they can miss something. By talking out the steps, it helps the evaluator hear what you're doing, and that way you'll get credit for it. The other thing that it will do is help you remember the next step, especially if you are reciting these steps to yourself. If you don't have anybody to practice on at home, you should be at least reading these steps out loud, because your brain processes information differently when you say it to yourself and when you say it out loud. So if you don't have anybody at home to practice with, or if you do, but you know, you find times that you're not, at least read the steps out loud so you know what comes next, and reciting it will help too. But here's the real reason that I want you to talk these steps out. All of that had to do with the test. I don't care about the test. Test is one day out of your life. One day. I don't care about the test. I care about the day after the test when you're out there working. And do you know who doesn't know what you're doing with their body? The patient. So you should be talking these steps out, not for you, but so that the person that you're putting hands on knows where those hands are going and what they're doing and why they're there. That's really why you should be talking it out. So it's not really about what words do I have to use to pass the test. You're not graded on any of that, as long as you're, explain to the patient what you are planning on doing and getting permission. But I want you to talk it out because of the patient. We want to make them a little more comfortable. Does that help?
Mm-hmm.
So there's no specific words you have to use or a specific amount that you have to say.
I was thinking if I would be talking to myself out loud, to directing it towards the person doing the observation or the patient?
Okay,
I can tell the difference now.
Yeah,
that I'll
that's-
be talking to the patient.
That's a great question. You should never talk to the evaluator. They don't exist in your world. The world is between you and the patient. And you want this to be a good representation of what you're going to do in the field. And in the field, you're not going to talk to yourself, you'll talk to the patient. So all communication should be directed to the patient during the test. Let's say that you're counting the pulse and you lose it and you've got to restart. You want to tell the patient, oops, sorry, I lost track, got to restart, not the evaluator. They're smart, they'll keep up. Don't worry about them. You want to talk to the patient because the person that's laying there that you're taking their pulse, if you don't say anything and you're just like, oh, okay, start, and you start over, they're going to be thinking in their brain that something is wrong with them. And what do you think that's going to do to their anxiety? Yeah, and what's that going to do to their heart rate? Elevate it. So it's really important that we're telling our patients what we're doing. We're keeping them informed.
And then for corrections, should we do it during the test?
Whenever you realize you made a mistake.
Okay, is that the only time we would really talk to the evaluator?
You're not even going to talk to the evaluator. Just, I would talk to the patient. Correction, I would have.
Okay.
Again, all communication should be with the patient.
So with that method, even if you do make a correction, it's just check marks, not points. It won't.
Right. Check mark is a check mark, whether you did it or corrected it, same check mark.
On the care plan, when it says left or right side, is that the side we start on or the side we want the patient on?
When it tells you to position the patient on their left side, that means that after the turn, now after the turn, the patient needs to be laying on their left side,
Okay.
which means you'll be on the right side of the bed. You're always opposite. Good. Any other questions? Those are all great questions.
You want to keep that blanket with them, right?
For the test, they won't. They won't. All right. Remember, that care plan is only for that patient. If you're turning a patient, your care plan might say something completely different than what this one said. Okay. For the test, this will be your care plan. But in a clinical setting, if your care plan tells you to turn a patient, it may not say those words. It may say something completely different. Remember, every care plan is tailored to that individual's needs. We're not one size fits all. Good? Make sense? Okay. All right, so let's talk about foot care. You guys remember hand and nail care? You guys remember hand and nail care? Well, you know how to do foot care. You know how to do foot care. The thing about foot care, though, is we're going to skip a couple steps. Foot care is hand and nail care. We're just going to skip a couple of steps, and I'm going to explain to you why in a minute. But if you look on page 118, you can see all of the principles that are involved. We know them all. There is nothing new to learn here. Nothing new to learn. At the bottom of the screen, you can see test-specific information. They're going to give somebody with your level of experience 13 minutes to do this skill. You're going to be doing it on another live testing student. Let me let that sink in for a second. You may be a patient for foot care. And I get it. Half of you in here are cringing already because you don't want anybody touching your feet. Go get a pedi before you go to the test. It's a good excuse. Go get a pedicure. You'll be fine. But this is a live patient skill. Nobody's going to be cheese gratering your heel. Nobody's going to be digging under your nails. Nobody's going to be, doing a hot stone, anything. This is simply soak the foot, wash the foot, rinse the foot, dry the foot, lotion the foot. That's it. That is the entire skill. That's it. But if it makes you feel better, use it as an excuse to go get a pedicure before you go to test. Test-specific instructions are located on page 119, and supplies are at the bottom of the page. We're going to talk about that. Remember I said it's just like hand and nail care, but we're going to skip a couple steps. Yeah. So here's our care plan. It says provide foot care to 1 foot. How many? What if they have 2? Yeah, we don't care. Don't care. They only, we're only doing 1. Now, for the test, they probably won't tell you which one. You get to pick. It doesn't really matter. In a clinical setting, if you're doing 2 feet, you can do them both at the same time as long as they'll fit in the basin. If they're big feet and they won't fit in the basin, do them 1 at a time. Nobody cares. Nobody cares. Just do the foot care. A lot of times we get all wrapped up in these little tiny itty bitty steps that don't really matter to anybody. Okay. So for the test though, where do those evaluators want to be? At home in their pool drinking their margaritas. They do not want to be watching you wash, rinse, and dry a second foot. If they saw it on the first one, they know you got it. Let's move on. Okay. That's why we're only doing 1 foot. But in a clinical setting, there are going to be times that you only do 1 foot. Like if the other one has an active wound. We probably don't want you anywhere near that active wound. If the patient has an infection on 1 foot, well, we don't want that in the water. If the patient's had an amputation and the foot is not there, you can't wash it. So there are lots of reasons why you would only have to do 1 foot in a clinical setting. But if the patient has 2, usually you're going to do 2. And it doesn't matter how you do that. 1 at a time is fine. 2 at the same time. If they'll fit, that's great too. Okay, good. Okay. All right. It also goes on to tell us the resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. Now, the reason that this is on this care plan has everything to do with the fact that our patient is a testing student. That's why we have to have this, this sentence. Because generally speaking, when you do foot care, you're going to put a new sock, a clean sock on that foot. Clean foot deserves a clean sock, right? That just makes sense. We're all on board with that. No problem. But the problem is that you're my patient, and chances are you don't have a clean set of socks in your back pocket. So how can I put clean socks on the patient if there aren't any? So for the test, they have to give us direction. Okay, there's not going to be any clean socks. What do you want me to do now? I want you to replace their sock and shoe at the end of the skill. That is why that sentence exists. It's telling you, hey, yeah, we know this is the test and there are no clean socks for you to use. So this is what we want you to do. Put their other sock back on. Okay, good. Okay. All right. So let's get into our skills specific steps now. And again, not much to learn here. Hand and nail care, we already know. Foot care, pretty much the same. We're still going to soak the foot in the basin just like we did the hand. We're still going to support the foot and leg when we move it in and out of the basin just like we did with the hand. We're still going to put that foot on a towel just like we did with the hand, right? None of that has changed. We're still going to check the water and let the patient check the water. We're not adding soap to the basin. All of that is the same. Nothing has changed here. We're going to soak it, wash it, rinse it, and dry it, just like we did the hand. Nothing has changed. Now, what is going to change here is that we are not cleaning under the nails. Not our job as a CNA. We don't do toenails. We don't do anything with toenails. We don't clip them. We don't grind them. We don't file them. We don't clean them. We don't do anything with toenails at all other than look at them. Because we have, bless you, we have in most healthcare settings a podiatrist, which is a foot doctor, special doctor, just does feet, that comes to the facility once a month and will see the patients that are on a list. You do foot care, you notice there's a problem, you tell the nurse that there's a problem, the nurse goes in and looks at the problem and then puts the patient on the list for the podiatrist to see. Okay? Bless you. Does that make sense? Everybody got it? All right. So because feet are often covered with shoes and socks throughout the day, they're hard to see. So usually once a week, we have CNAs look at everybody's feet once a week. It's important Because if there's an issue and it's covered by a shoe and sock all the time, nobody's going to know the issue exists. And issues can get out of control then. Make sense?
So, if their nails grow faster or something, like I know as a CNA it's not your job, but can't it irritate the nail like in your shoe and everything?
You'll report it to the nurse. So generally speaking, as we age, toenail growth slows down dramatically. So where you probably, generally speaking, I'm assuming you're probably in your late teens, early 20 time, age range, right? You probably clip your nails about once every 3 to 4 weeks in general, your toenails, right? When you get into your past your 20s into your 30s and 40s, you add a week. When you get into your 40s to 50s, add a week. When you get into your 50s to 60s, add a week. When you get into your 60s to 70s, add a week. So you can start to see that toenail growth is going to slow dramatically. And instead of clipping your nails every 3 weeks, we're now clipping our nails every 3 months. So if you're doing this once a week, there should never be a situation where the nails grow enough to affect the patient. Does that make sense? Okay. All right. The other change here, the other accommodation that makes it different from hand and nail care is when we put lotion on the hand, we lotioned everything. When we put lotion on the feet, we do not put lotion between the toes because between the toes is really protected. And when you put lotion there, it's going to hold in moisture. And then we put a sock and shoe on top of it. Now we've got warm, dark, moist. So and that's a really good place for athlete's foot to develop a fungal infection. So no lotion between the toes, everywhere else, but not between the toes. The real reason you're doing this skill, guys, is not to clean the foot. Cleaning the foot has nothing to do with this skill. It's why you're there. You're going to get a basin of water. You're going to clean the foot. It's you're doing the steps. That's not why you're doing the steps, though. It's not about cleaning. It's about looking. This whole skill is about looking. And that's because shoes cover feet. And wounds can happen, particularly in diabetics. Wounds can happen that don't get recognized. We don't realize that there is a wound there. And then it festers, gets worse and worse and worse and worse. And before we know it, we have a major wound on our hand that nobody knew existed. That's why you're doing foot care. So a big part of the skill is to look at all surfaces of the feet. We used to have CNAs. We would tell them, hey, once a week, I need you to make sure you're looking at the patient's feet. Give it a good once over. And the CNAs would walk in, they'd lift up the sheet and they'd go, okay, yeah, you got feet. I don't know why I had to do that. And they didn't understand why they had to look. They were looking for wounds, rashes, sores, anything out of the ordinary, toenail issues, whatever the case may be. They didn't do their job. And because they didn't do their job, wounds got missed and amputations went up. So nurses said, okay, how can we get these CNAs to actually look at the feet? Let's make a skill, foot care. Because we figure if you're soaking the foot and washing the foot and rinsing the foot and drying the foot and lotioning the foot, at some point in that process, you might actually look at the foot. So you can thank all the old CNAs out there for you having to learn this skill. They did not do what they were supposed to do. Therefore, you now have a new skill to learn. This is important for you to understand because that's exactly what nurses are going to do. If you don't do what we need you to do, we will find a way to make you do it. And that means more skills, more time. It takes a whole lot less time to look at the feet than it does to do foot care. Make sense? So when a nurse asks you to do something, they need it done. There's a reason they're asking you to do it. Don't ignore it. Make sense? Yeah. I've got a story that I tell about this. And I usually tell it in a different lesson, but let me go through it really quickly with you so you understand this, why this is so important. It's a real story. This happened many, many years ago. I was working in a nursing home that had a long-term care setting attached to it, a rehab wing. And I'm sorry, I was working for an agency. I got assigned to this place as a substitute nurse. I'm on the rehab side. I go in to see the first patient, and when I walked in his room, the lights are dark. Now it's early morning, really early morning, like 7 a.m. I don't do mornings. The light is off, but he's got one small light above his bed. And as I walked in, I flipped the light on, and he immediately started yelling, "Turn the light off, turn the light off." So I turned the light off and walked up to the bed, and I said, "Hey," we're going to call him Henry. "Hey, Henry, my name is Patty. I'm your nurse today. I'm a substitute nurse. I'm here to do an assessment and give you your morning medication." He's like, "Do what you got to do." He was really gruff, kind of no nonsense type guy, but he was young. He was in his early to mid 50s. He was young for rehab, young. So as I'm talking, I asked him, "Why don't you want the light on? What's going on with you?" Because there's a story there, right? People don't just not want, there's a reason. He says, "Yeah, I've got diabetic retinopathy and the bright light really hurts my eyes." Okay, sounds reasonable, no problem. But as I'm sitting there talking to him, I'm catching an odor. There's a whiff. And if you've ever smelled a wound, they're very distinctive. And I know this guy's got a wound somewhere because I can smell it. And I pull out my report sheet, and I'm looking at my report sheet, and there is nothing on here about wound care. That's not good. That's more work for me. So I tell him, "Hey, Henry, I need to take a look at you because I think you might have a wound brewing somewhere, and I got to find it." He's like, "Do what you got to do." So he turned over, and I looked at all the usual suspects, the ones we just talked about, the back of the head, the tips of the ears, the shoulder blades, the lower back or coccyx area, the back of the legs, back of the calves. Get down to his feet, and he's got those slipper socks on. You know what, the ones with the white dots on them? And I said, "Henry, I need to take your socks off and look at your feet." And he immediately barked out, "No." Okay. Why not? He says, "I've got neuropathy, diabetic neuropathy, and if you touch my feet, it really hurts. I don't like anybody messing with my feet. Don't touch my feet." I said, "Okay, I get it. I understand it. Neuropathy really, really is horrible. However, I think you've got a wound, and I've got to find it so it doesn't get any worse." So I turned up the charm. You could always get further with patients by being charming than being mean. So I turn up the charm, and I get him to finally agree to let me take his socks off if I'm going to be really, really careful. And I took the left sock off, and it was fine. Foot was a little flaky, needed to be washed, but nothing serious. I go to take the left sock off, and it's stuck to the bottom of his foot. Found it. There's my wound. But I have no idea what the wound is because I can't get the sock off yet. So I go get a basin of warm salt water. We call it normal saline. And I put the whole foot, sock and everything, into the basin to soften so I can get the sock off. I go take care of another patient, come back after 10, 15 minutes, get my gloves on. Gloves because there's a wound. And I tried to take the sock off, and it was still pretty stuck to his foot. And I had to use a little bit of force to just kind of get the sock to loosen. And as I did, something went flying past my head. I start counting toes. 1, 2, 3, 4, 5. They're all there, thankfully. It's okay. What went flying past my head? So I start looking around on the floor, and the molding, the baseboard was like this. It was, the wide plastic mold. And the floor was like the speckled industrial flooring. And it took me a minute to find it because it kind of blended in. But it was one of those, here, I'll show you. One of these. A flat metal white thumbtack. One of these. This was what was stuck in the bottom of his foot. Now, you or I, if we stepped on a thumbtack, we would certainly know it was there. Absolutely, we would know it was there. And we'd be hopping around, yelling and screaming for somebody to get that thing out of our foot. So how is this guy walking around with a thumbtack in the bottom of his foot and not yelling and screaming? Neuropathy. Neuropathy is kind of like static on the line. So the nerve that connects the foot to the brain, it's all corroded with sugar. The signal can't get through. There's static on the line. So the foot knew there was a thumbtack there, but couldn't get the message to the brain. He had no idea this thumbtack was in his foot. No clue. Now, we don't know how long that thumbtack had been there because he liked the room dark. And the CNAs were not allowed to touch his feet and did not report that to the nurse. We have no idea how long this thumbtack was in the bottom of his foot. Now, no one saw it because those little white dots on the bottom of the socks, yeah, the thumbtack just blended right in. So by the time I get the sock off and I'm looking at the wound, it's about this big around, hard black dead tissue. Now, in healthcare, we can heal a lot of things. We've come a long way with wounds. We can heal a lot of things, but dead is dead. There's no coming back from dead. We aren't Dr. Frankenstein yet. We can't reanimate dead tissue. So I know this guy has got a long road ahead of him, and it's not going to be a good one. So I call the doctor, I take the pictures, I call the wound care specialist, I get the orders, I do the wound care, I call the family, I write all my notes up, take care of my other patients, and I leave. Not my patient, not my facility, not my problem. But this guy stayed on my mind for a long time because he was in his early to mid 50s. He's young. And this is bad. About 9-10 months later, I have no idea how long, I get reassigned back to that facility. Now I'm on the long-term care side of the facility. And I look down my report sheet and I see Henry's name. So this means that Henry wasn't able to go home. This is now his home. In his 50s, this is now his home. So I walked in the room. Hey, Henry, I'm Patty. I'm the nurse that found the wound on your foot. How are you doing? He pulls the sheet aside and he had to have a below the knee amputation. He lost his leg. Yep. Now, what made this particularly horrible is it was 100% preventable. Because if he had shoes on, where would the thumbtack be? In the shoe. That's right. Do we amputate shoes? No. If you have a diabetic patient, do not let them walk in slipper socks. They provide zero protection. None. How many of you guys have ever been a patient at a hospital? And when you were a patient at the hospital, you got a hospital gown and a pair of complimentary slipper socks. And you probably put those socks on and then you walk to the bathroom and you walk to the hallway and the nurse's station. And you probably walk downstairs to the subway because the food they serve there just isn't very good. And as you're walking all around, you're picking up all those pathogens on those slipper socks. And then you get back into bed. And what gets into bed with you? All of those pathogens. Now, these aren't Walmart grade pathogens, are they? If you've got any wounds at all, those pathogens are going to cozy right up into that wound because it's warm, dark, and moist. And now you've got a surgical site infection. How did that happen? It happened because you walked on unclean floors and slipper socks and brought those pathogens right back into bed with you. Shoes are a necessity. But this is why we have to do foot care. Because wounds happen. Injuries happen. And if we don't pay attention to the injuries and treat them when they happen, we end up with patients that have to lose body parts. And that's not fair. Make sense? Foot care is important. This guy, if somebody had put shoes on him, would not have been in this situation. This guy, if somebody had looked at his feet, we would have caught the wound early. But instead, when he said no, the CNAs were like, okay, no skin off my nose, and they go do something else. And they didn't tell the nurse. Nurse was unaware. Everything you know, the nurse needs to know, no matter how minor it is to you. Because every decision you make to not tell a nurse something is going to have a consequence. But it won't be a consequence to you. Who's the one that has to bear that consequence? The patient. Yep. We shouldn't be making decisions for other people's health care. Make sense? Good? All right, so first we're going to read the care plan. Then we're going to do our opening. We're going to wear gloves for this because we don't know if there's a wound. The whole purpose of us being there is to look for a wound. Because we don't know if there's a wound, it's a maybe, we need some gloves. We're going to use a barrier. This time we'll put it on the floor because your patient's probably not going to be able to get their foot on the table. Okay. Some of us are bendy enough to do that. Most of us aren't. So we're going to put the barrier on the floor, and we'll put all of our supplies on the barrier on the floor. Don't put the towel on the floor itself. Make sure it's on the barrier. Now you can't put a second barrier down to kneel on if you want to. Perfectly okay. Nothing wrong with that at all. But remember, your uniform isn't clean once you start working anyway, so it doesn't matter. You don't have to have a barrier, but if you want one, that's fine. Me, I'm getting old. My knees not as good as they used to be. I don't just want a barrier. I want like 4 layers of towels to kneel on because my knees don't work the way they used to, right? None of that is graded. It doesn't matter whether you kneel on a barrier or not. I think personally that they should have those little rolling stools during the test, but they don't. They don't. A lot of facilities are using those now, which is really cool. A lot of facilities are using those now, but the test still hasn't integrated that yet. I think they should. Let's petition. Let's petition. All right, we're going to follow our washing rules. Get water, check it. Should feel warm, not hot, not cold. Let the patient check it. Whatever you wash, you rinse. Whatever you rinse, you dry. Don't put soap in the basin. And apply lotion last. Warm it up first. Okay. We'll clean that basin when we're done. That water can just be thrown in the sink. It's fine. It's it's not body fluids. It's fine. If you want to put it in the toilet, put it in the toilet. Nobody cares. You're going to see all kinds of debates online over this. Nobody cares. It's bathing water. It can go in the sink. So our skill-specific steps is we're going to soak the foot in the basin, and then we're going to provide support to take it out of the basin. We're going to wring our washcloth out, put soap on the washcloth, and then we're going to wash that foot, put it back in the basin to rinse it, take it out to dry it, making sure it's on a towel every time it's out of the basin. We're going to, as we're washing, rinsing, and drying, we're going to be looking. And then when we're ready to put the lotion on, after we've dried the foot and we're ready to put the lotion on, no lotion between the toes. Your whole purpose here is to inspect. You should be looking. Hopefully for the test, your patient won't have anything to report. This is why you should all go get a pedi, right? But if there is something, if you notice something during the test, you can say, I would report this scratch. It's perfectly okay to say that.
If there's like a big wound on the foot, would you discontinue?
That's a great question. So now let's shift from tests to real life, right? So we're doing foot care and we see a wound. Do we want to put soap in that wound? No, not a good idea. So what we would do is stop what we're doing right away. When you put that foot in the basin, if you see a wound, you're going to stop. Let's go get the nurse right away. Because first of all, we don't want to finish foot care. We don't know what that soap would do to the wound. Secondly, if you finish foot care, get the patient some shoes and socks and get them all buttoned up and then go let the nurse know, hey, I found a wound on the patient's right foot. I'm going to say, is it accessible? Can I look at it? And you're going to go, no, I've got the shoe and sock back on and they're in the activity room. How am I supposed to look at it? So what I'm going to tell you to do is, okay, go get the patient, take their shoe and sock off, put them back in their room, and I'll be in to look at it in a little while. I'm going to make you do the work. And you've just tripled your work. So the better idea is make sure your patient's safe, leave them there, go get the nurse right away. Hey, there's a wound. I'm doing foot care. Wound is open. Can you come give me some direction here? And the nurse will stop what they're doing and go look, because the wound is accessible and you need instructions.
As a product of Gen X male, I've never done pedicure, never done manicure, none of that, never really desired to. What is an appropriate time to soap? Like I know hand washing, got 20 seconds. What's an appropriate soap?
Okay, for the test, we're just going to put it in the basin, and that's sufficient. Nothing. But in a clinical setting, usually 5 to 10 minutes. 5 to 10 minutes. 2 to 4 minutes for the hand for soaking. That just loosens up all the debris under the nails sufficiently to, clean it well. Foot care, I get the patient set up. They're sitting in a chair at the side of the bed. The care plan told me they were. Get the patient set up, get their foot soaking. Go take care of somebody else. I'm going to walk somebody down the hallway or take them to the bathroom or give somebody a snack or whatever, whatever other tasks I need to do that I can fit into that time frame. That's what I'm doing. I've washed my hands. I've left the room. I'm going to take care of somebody else. I'm going to come back in 5 to 10 minutes and finish up foot care. I'm not going to stand there and stare at the patient for 5 minutes. Because then I have to fill that time with small talk. Now, I don't mind talking to patients. I can usually find some common ground. But if I've got other tasks to do, this would be a good time to do them for time management. If I'm in home care and I've only got one patient, yeah, we're going to talk about, last night's, the Bucks played the night before last. Let's talk about that game. That was a really good game. I mean, talk about the last minute of the game. It was a good game. So if I've got a male patient that is up on football, we are going to have a long conversation about that game. Yeah. So somebody had.
I didn't reflect here, but on the test and in general, it is important to go in between the toes to dry them off with the towel.
Yeah, I'm going to actually show you that in the video. I
Okay.
take an edge of the towel and just blot between the toes. Because again, warm, dark, moist. Okay. Don't let the bare feet touch floor. That just makes sense. And we're going to replace the sock. Make sure you remove as many wrinkles as possible when you put the sock on. Don't have it all bunched up and wrinkled and, you want it as smooth as possible. And then just secure their shoe before you clean up. And then you'll clean up your environment and do your closing. That's the whole skill. It's not a hard skill. It's only on one of those care plan sets. So remember, there's 11 care plan sets. Foot care is only on one. So you only have a 1 in 11 chance of getting this skill. Those aren't great odds. But I will give you a little secret. The skill that you dread is the one that you get. Yep, the skill that you dread is the one. And this is, I've had literally thousands of students that came back and told me that, oh my gosh, I really, really, really didn't want foot care and I got it. Or I really, really, really didn't want pulse and I got it. Or I really, really, really didn't want peri-care and I got it.
Being done to them, or they had to do it?
They had to do it, demonstrate it. So my suggestion is, if there is a skill that you are finding particularly difficult to perform, you need to practice it twice as much as the rest of the skills, because whatever it is that you're dreading, I don't know, I'm not into manifesting or anything like that, but I'm telling you, it happens. It happens, whatever skill you are dreading. So if you don't like to do foot care, if feet kind of freak you out or whatever, and you don't like this skill, I would absolutely be practicing it, because chances are you're going to get it. I don't know how it works. It just does. If I believed in manifesting, I would be on a beach somewhere, guys. I would be live streaming from Tahiti.
Does the other test subject you're testing with get the same skill stuff that
Nope.
you do?
Not usually. So remember, they are going to pair you up into groups of 2. They know based on your prometric code what your skill set is. It's actually coded into the number. So they know what your skill set is and what yours is and when you check in. So usually that's one of the criteria that they're looking for. If you have skill set 7, I don't want to partner you up with somebody else that has skill set 7. So it doesn't mean you can't. If all the other stars are unaligned, I might not have any other choice in partnering you up with somebody with skill set 7. Because of, you've got a mouth issue. I can't do mouth care or denture care with you. You've got food allergies. You can't do feeding. You sprained your leg. So I can't, everybody's got something now. So that may affect it. But in a perfect world, we would not put 2 of the same skill sets together. And in reality, it really doesn't matter, because by the time you get to testing day and you're watching somebody else do the skills, you're not about to learn the right way to do something. before you're testing. I mean, the time for learning is way past. So it really doesn't matter if you guys all have the exact same skill set. You might do them a little bit differently, but I don't care how different you are than other people. What I care about is, do you check the check boxes?
You said that before they take us in to do the test, we sit in a room for like 30 minutes. So like,
Probably more like 20 as they are working to pair you guys up. Yeah.
and then you said about don't bring your stuff in because you can bleed.
Right. So once they pair you up, okay, and let's say you two are group 1, you're group 4. You've got like 2.5 hours to kill. You don't want to stay in that waiting room. Go out to your car and study or read or listen to an audiobook or play a crossword puzzle. I don't care what you do. But they'll tell you when to come back. They'll say, I need you back here in 2.5 hours.
Because they don't, then nothing is going to go faster or slower than.
What they do is they give you the basically the minimum amount of time, and they'll tell you when to come back based on that. You probably will have to wait. Once you come, if I tell you to be back in 2 hours and you come back, you may still be waiting for 30 or 45 minutes before your turn. They're good at judging that. Remember, this is their full-time job. They know when to tell you to come back.
It says the resident is sitting in the chair, in their sock shirt, whatever. Since they're sitting in a chair, in the skill set between each skill, will you leave?
Okay.
As a reposition, or-
Yeah, so that's a great question. Think of those evaluators as the director of a play. They're going to set the scene. So they're going to make sure that the right patient is in the right place at the beginning of each skill that you have to do. That's why you have to end one skill before moving on to the next. So there's going to be like a little gap in time. Some skills you'll be doing on the mannequin. So those skills, they're going to, tell you, because you're her partner, they're going to go sit down over there. Your next skill will be on the mannequin, and they'll make sure the mannequin's in the bed. So they set the scene.
So you just like stand there?
Yeah, you just stand there.
How do they do stuff for skills? Like I know you said with like the preset or whatever. Like how do they know that? Is it based off of what you're doing in class here, or like?
So the skills are actually set by the Board of Nursing. There are 20 skills that you can be tested on that the Board of Nursing has defined. And it's all based on a national organization that sets skill standards kind of nationwide. Okay. These are appropriate CNA skills. And then each state pulls from those sets of skills and defines criteria that they want their students tested on. So that all gets packaged up and then transmitted to the testing company, which in our case is Prometric. But it's all set at the state level.
Prometric evaluates us to, which skills you're going to do. Do you fill out a questionnaire like, hey, I don't want anyone messing with my mouth or whatever, and that's how they decide who gets what? Or,
No.
because you were saying they evaluate for the best person for.
Right. So when you register for the test, and we're going to do test registration today. When you register, we're going to hand out the paperwork. Okay. You'll register when you decide to register. When you register for the test, you are going to get a Prometric ID. That Prometric ID actually contains your skill set. The computer picks it. So the computer assigns your skill set. So in your Prometric ID, if you have, let's say that, at a certain place in the ID, you have a number 5. That means that you have skill set 5. That's what you are doing. Now, we've got to find a patient for you to do skill set 5 on. Out of all of these people, I'm sure I can find somebody that I can do all 3 of those skills on. Now, some of the things they're going to look at are things like physical mobility. If you've sprained your ankle, then I'm not going to use you for transferring or range of motion, hip, knee, and ankle, or walk, ambulating, which is walking. So it's going to knock you out. You can't be a patient for those skills. And that's what they're going to look at when they check you guys in, is who has what problems. They're going to assess you. They just kind of look at you, and then they're going to ask one question. Do you have any conditions that would prevent you from being a patient for any of the skills? And then you self-report.
Going back a little bit to the socks, like the slipper socks, do they protect from any sort of infection, like staph infection or plantar warts? And if not, why do we still use them?
Do you remember gloves? Do you remember how we thought gloves did a certain thing and then we found out they really didn't? Slipper socks are the same thing. So they do help a little bit. They have the grippers, right? They do help a little bit with slips, but they generally tend to turn because there's no real defined heel. And then you end up walking on the part that doesn't have the grippy things. So does it really help? No, not really. So what should we be wearing when we're out of bed? What would be a better source of protection? Shoes, absolutely. Very few people are in a facility without shoes. They're just usually in a bag in a closet. We have to go get them. But we don't think about that. We're so ingrained. You know, you're in a clinical facility, you put your socks on, and that's what you walk around in. I mean, you probably didn't even give it a single thought. And most of your nurses aren't going to give it a single thought because they haven't heard this lecture. As a nurse, I didn't think about it until somebody pointed it out to me. And now I'm like, ugh. Tanny, is it when you get to the testing location, you will know the skills you're going to be tested on? Yes, that is correct. When you get checked in, actually, you won't even know when you're checked in. You won't know until you go into the testing room what your skills are. Yeah, because otherwise, that would be unfair. That would be unfair. If you two are group one and you're going to test right away, and I tell you what your skills are, and then I tell you what yours are, and I go around the room. Now, everybody knows what their skills are. You've got 2 hours to study up on yours, but you're testing right now. Is that fair? No. So you guys all get notified right before you do the skill. But that's just like a clinical setting, right? Nobody's going to call you up the night before and tell you, okay, tomorrow when you're taking care of patients, these are the skills that you need to know how to do. Nobody's going to give you any advance warning. When you walk into a room, you've got to know what to do. This is no different than that.
So, probably a question, but if your written test is the same skills as your clinical?
No, written test is going to test us on not skills. We're going to have questions on infection control. We're going to have questions on communication. We're going to have question on recognizing emergencies and what to do about them. Yeah, guys, a question that I did yesterday, but I'm going to pass on to you guys. Fires and patients can never be in the same place at the same time. That makes sense, doesn't it? A fire and a patient cannot be in a same place at the same time. So if you walk into a room that has a patient in it and a fire, what do you need to do? Remove the patient. That is always step one. Patients can never be in the same place as a fire. Do not grab that fire extinguisher and try to put the fire out. Don't do it. Move the patient, because a patient cannot be in the same place as a fire. Make sense? That would be a written test question. You walk into a patient's room, you see a fire. What is your first action? Yeah, save your patient.
I had a question about that. On the test we did on the back, I think it was chapter 3, it was asking what you do first, and it was, how come you don't pull the fire alarm first? Because it takes like 10 seconds.
Doesn't matter. Patients and fires can never be in the same place at the same time.
So when would be a good time to pull the fire
So we remember RACE tells us how to work with a fire. So R is rescue or remove the patient. Always number one. Always, 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 always. And then alarm. Activate your alarm system. But you have to get the patient out of the room.
I just wasn't sure because if the fire is going quick and you can pull the alarm, wouldn't it help
Nope.
other people?
Nope. Always remove the patient from the area of the fire first. Always. Let me give you an example of this. This is a real life example, and we are like way late, guys. All right. Let me give you an example. Real life example. Rainy days are very dangerous in healthcare, particularly long-term care health. Nursing homes, assisted living facilities, rainy days are really, really dangerous because patients that smoke can't go outside and smoke. They're not going to quit smoking because it's raining. They're going to smoke in hidden places. That's usually linen closets, bathrooms, right? Places that have flammable objects. And if they think they're getting caught, they usually will panic and then throw a cigarette or bury it or do something with the cigarette that does not put it out and starts a fire. This happens routinely, often. You'll also have little tiny 80-pound-year-old women climbing on the back of the toilet to get up near the fan to smoke a cigarette. It's crazy. And then when they fall and break their hip, makes me crazy. Rainy days are dangerous. I want you to remember that. If you have a rainy day and you are working in a long-term care facility, you need to know where your smokers are at all times, because they are not going to stop smoking because it's raining. It's not going to happen. Okay. So on this particular day, there was a patient. This was a long-term care nursing home side. Okay. Patient in a room, and it was raining out, and a male CNA, let's call him Johnny, was walking down the hallway and smelled cigarette smoke. So he backed up a couple steps and looked in the patient's room. And just in that time, right, the patient realized he was caught, panicked, and threw the cigarette into the trash can right beside the bed. Now, inside the trash can is a bazillion paper towels. We wash our hands, we throw the paper towels away. Those are flammable. So Johnny walks into the patient's room and sees the trash can smoking. No fire, no flames, just smoking. So Johnny thinks, I got this, no big deal. He goes and grabs a fire extinguisher, picks up, takes it to the room, takes the nozzle and puts it down inside the trash can where it's smoldering. No flames, just smoke. Puts the nozzle inside, squeezes it, pulls the pin, squeezes it, and all of that foam comes out, but it comes out under pressure, which means that everything that was in that trash can smoldering is now all over the room. The patient was on oxygen. Now, oxygen is going in through a plastic tube in the nose. It's called a nasal cannula. It's a plastic tube. But the thing about oxygen that's really cool is it's dense. And when you have oxygen, it's not just going in the nose. It actually creates this like little cloud area because it's dense right around the face. So as these smoldering paper towels hit the oxygen, it flames up. And now we've got fire here. And the patient, obviously, because this is what we would do, breathes in. Now, that oxygen or that fire is going to follow the flow of oxygen. So what did the patient breathe in? Fire. If Johnny had removed the patient from the room, even he made a million mistakes with that fire extinguisher. Those were all mistakes. But if he had removed the patient from the room and made those mistakes with the fire extinguisher, would the patient have suffered? No. This is why patients and fires can never be in the same place at the same time, because we cannot trust that you're not going to make a mistake in your panic. Make sense? Sad situation. True story.
He was okay though.
No, he was not. All right, Jake, can you put up foot care for me, please? Hello, good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I'd like to perform foot care on your right foot per the care plan. Is that okay?
Yes.
Let me close your privacy curtain, wash my hands, and get my supplies, and I'll be right back. After washing my hands, we'll gather our supplies. We're going to start with a barrier on the floor under the patient's feet. So we'll spread the barrier out. And can you move your left foot to the side, please? Thank you. I'm just going to place this barrier on the floor. If you can lift your foot. Thank you very much. And we'll move that shoe out of the way. We'll also need a basin, soap, and lotion. Once the barrier is in place, we're going to get 1 towel and 2 washcloths and take them to the patient's area. You can place a barrier on the floor to kneel on, but this is optional. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature?
Oh, that's beautiful.
Very good. I'm going to set this down. For this skill, I need 1 set of gloves. I'm going to go ahead and put my gloves on before we get started. And then I can take your sock off. We're just going to lift your foot and remove your sock. We'll set your sock to the side, being careful not to overextend, and place your foot into the basin. After your foot has soaked for a few moments, I'll place the washcloths in the basin and rinse your foot, and then lift the foot out and place it on the towel, wringing out one of the washcloths and applying soap. We'll apply soap to the top leaf and then wash all surfaces with short, soft strokes or a patting motion. We're going to wash down each one of the toes and then get in between the toes. And then gently we'll lift the foot with support and inspect the bottom of the foot while we wash all areas from top to bottom. And then we'll set this washcloth aside and place the foot back in the basin to rinse. We'll use the second washcloth to rinse the foot, squeezing the water to make sure that the foot has been rinsed well. I'm going to unfold the towel and lift the foot and place it on the towel to dry. We'll blot the foot dry around the ankle, the top of the foot, the heel of the foot, and then we'll lift the foot gently to dry the bottom. We'll take an edge of the towel and slide it gently in between each toe to blot to make sure no moisture remains behind. Now that the foot is dry, we'll get some lotion, warm it up in our hands, and then apply it to all areas of the foot except between the toes. So the top of the foot, the heel of the foot, and the sole of the foot, but not between the toes. And then we'll wipe off the excess lotion. The care plan has told us to replace the patient's sock. So once the lotion has been removed, I'll take the sock, make sure it's right side out, and scrunch it all the way up to the toe seam. We'll put the sock over the foot making sure the toe seam lines up across the toes, and then we'll secure the sock over the heel, minimizing wrinkles and making sure the sock fits appropriately. And then we can gather our dirty linens and place them in the soiled linen hamper. So we'll place our soiled linens in the soiled linen hamper. Now we can clean our basin. I'll bring the basin to the sink. We will dispose of the water in the sink, rinse the basin, and then dispose of the rinse water in the sink as well. I'm going to set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. We'll dry the inside with a paper towel. Throw that paper towel away. Dry the outside with a paper towel and throw that paper towel away. And then get one more for the drawer. After cleaning the basin, we'll use the paper towel to pick up the soap and the lotion and return the basin to storage. We're going to put our supplies away by opening the drawer with a paper towel. We're going to put the basin, soap, and lotion in the drawer, close the drawer with a paper towel, and then we'll throw the paper towels away. And then we'll remove our gloves, being careful not to contaminate our hands. So now I'm going to gather the barrier, and we'll throw this away, and I'll help you put your shoe back on. There you go. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm going to go open the curtain and give you your call light.
Thank you.
Okay, Mr. Jones, here's your call light. If you should need anything at all, just press that red button. I'll be happy to come back and help you.
Thank you.
Is there anything else I can get for you before I wash my hands?
No, thank you.
Okay, have a great day. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, any questions on foot care? It's pretty easy, honestly. I mean, as far as a washing skill goes, you wash it, you rinse it, you dry it, you lotion it, that's it. I mean, there's not a whole lot to think about here, okay? All right, so we're going to move on to mouth care. I'm going to make this pretty quick. We have 2 skills to go, mouth care and respirations, and then we're going to get into test registration instructions as well. But mouth care is actually pretty easy. There's not much to teach you because you guys have all got experience with brushing teeth. How do you brush teeth? I mean, you wet the toothbrush, you put some toothpaste on it, you brush, you rinse, you spit, and you dry off. I mean, there's not much here to really think about, right? Other than the fact that your patient is laying in bed. So that's not a safe position. We've got to get the head of the bed up. I'm going to tell you that putting the head of the bed up is a graded checkpoint. It is an important checkpoint. If you don't put the head of the bed up, you will fail the test just on this one checkpoint alone because it has a serious consequence to the patient. But they do not grade you on how you put the head of the bed up or when you put the head of the bed up, as long as you do it before you brush their teeth. So you can do it during your opening. They don't care. You can do it after you've washed your hands. They don't care. That's not a graded checkpoint. They don't care about that. But I want to be a little more intentional about this. When you put the head of the bed up, that pillow that's behind their head is actually going to force their head forward. And that's not a comfortable position for mouth care. It's not safe either. What we want to do is have the patient lean their body forward and put the pillow behind the back. But we have a rule. We can't touch the patient until our hands are clean. So if you Put the head of the bed up during your opening. Don't reposition the pillow until you've washed your hands. Okay, good. If you wash your hands and then put the head of the bed up, well, now we're touching a bed controller that's probably not clean with clean hands. So if you use a paper towel between your clean hands and the bed controller, you can solve all of your problems at once. Good. So that's how you're going to see me do it in the video. You're also going to see that in the steps. But I'm going to tell you, it's not graded. When you put the head of the bed up, they don't care as long as you do put the head of the bed up. They aren't grading on infection control like I would. Honestly, they're not that strict. I think they should be, but they're not. Okay. So if you look at page 92, you can see all of the principles involved here. We're going to read the care plan. We're going to do our opening. We will need gloves because we're working with body fluids. You need a barrier to put all of your stuff on. Linen rules are going to apply. Don't hold the towel against your chest. And we're going to clean the basin like we clean all basins. And we're going to do our closing like we end every single skill. There is nothing new to learn here, guys. As far as mouth care goes, the actual brushing of the teeth, you guys all know how to do that already. So this is kind of an easy skill. But boy, is it awkward. This is awkward. You've been brushing your own teeth since you were about 4 or 5 years old. It is seriously awkward to have another adult in your mouth when they don't have any need to be in your mouth. Okay? You're not going to be brushing people's teeth that can brush their own. They will do. This is one of those skills that patients will hold out on as long as they possibly can. They will brush their own teeth as long as humanly possible. But if you do have to help somebody by brushing their teeth, do a good job. Okay? Do a good job. Don't take shortcuts on this. There was a young man that I took care of. He had been in a motorcycle accident, no helmet, went flying off a motorcycle, hit a tree with his head. That's never a good outcome. Broke his neck, actually just below his neck, was paralyzed from shoulders down, and it had been in the ICU for weeks or months. I mean, long time. This guy was touch and go. Didn't know if he was going to live, and he was only like 20, 21, super young. By the time he came up to my unit, which was the step-down unit, he was going to have to go to a nursing home because his family all worked, couldn't take care of him. He needs total care. He was going to go to a nursing home, but he had a period of time in between where we had to get him stabilized, get all his medications worked out and everything before we could transfer him out. So I get him. And I notice he's not talking a whole lot. And when he does talk, he turns his head away from me. And he's 1, 2 words. That's it. And I'm thinking, okay, this guy's probably pretty depressed. I mean, this is a life-changing event. Everything in his life has just changed. He's probably pretty depressed. Maybe I should get a psych consult. But I start talking to him before I do that to try to figure out if I can kind of see where we're at. And what came out was the reason he was turning his head away wasn't because he was depressed, although he probably needed a psych consult. This is a big change, all of that. But that wasn't the problem. Nobody had brushed his teeth the entire time that he was in the ICU. Nobody. Weeks, months. Nobody had brushed his teeth. He knew he had massive dragon breath. He was afraid he was growing green stuff on his teeth. He did not want to open his mouth for anything because he was embarrassed. Who should have been embarrassed? Us, for failing this guy. If he can't brush his own teeth and we're supposed to be brushing his teeth and we did not do that, that's a failure on us, not him. And yet he was embarrassed. So I ended up getting a dental consult on him. They had to pull like half of his teeth. It was horrible. Horrible. So we really failed this guy. You know, on top of all the other trauma he's having to deal with, now he's got to deal with this too. That's not fair. We failed him. So if you have to brush somebody's teeth, do a good job. And if you know somebody can't brush their own teeth and there's nothing on the care plan telling you to do it, you should be questioning that. You should be asking the nurse, hold up, this guy can't brush his own teeth and there's nothing on the care plan. Who's brushing his teeth? Because somebody needs to. Bring it up to the nurse's attention. Remember, when I am writing care plans, I've done a whole head to toe assessment. I'm writing out those care plans, but that is not all I am doing. I am talking to doctors. I am taking orders over the phone. I am dealing with issues and crises. I'm answering questions from families. I'm relieving another nurse for lunch. Do you think that occasionally something might get missed? We work as a team. If you notice that something isn't on the care plan that you think should be, bring it up. Good? Good? Okay. Supplies are all along the bottom. You've got to memorize your supplies here. And here's our care plan. It says our resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. We're going to do that for them. Now, somebody in here is going to ask, what about dentures? We're going to cover that next week. Have a whole skill on dentures. All right, so here are our skill-specific steps. We're going to follow our care plan. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I need to brush your teeth. Is that okay? Close curtain, wash hands, get supplies. I'm going to start out with a barrier. I'll put the barrier on the table. This skill will require gloves because we're working with body fluids. So we're going to put a barrier on the table. We're going to get our gloves. Our towel, our toothbrush, our toothpaste, our cup of water, and our basin for him to spit in. When we're all done, we're going to clean that basin like we clean all other basins. You're going to dump it, rinse it, set it down, use paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and one for the drawer. So skill-specific steps, you want to make sure the patient is sitting upright. They don't care when you do it, just do it. I personally will do this after I wash my hands using a paper towel between my fingers and the bed controller. Once you get the patient in that upright position, slide that pillow down behind their back. Remember, we have a checkpoint. You can't touch the patient until your hands are clean. So if you get them sitting up during your opening, don't put that pillow down behind their back until you've washed your hands. This is why I teach you in this order, so it starts to make sense to you. All right, so the best way around it is to do your opening, wash your hands, and then use a paper towel to put the head of the bed up, and then adjust the pillow. You want to put a towel over their chest because they will get toothpaste all over them. When you are brushing your teeth at the sink, you lean forward so that all that foam and mess goes into the sink. It drops down. If you're sitting up like this, all of that foam is going to go right here. It's not going to go in a sink. So we want to protect their clothing. Wet the toothbrush, put some toothpaste on it, and then brush. There's no time requirement. You don't have to brush for 2 hours. You don't have to brush for 2 minutes. You don't have to, just brush. Brush top, brush bottom, brush front, brush back. Brush. Don't overcomplicate it. Let them rinse as much as they need to. Here's a hint. If you use a lot of toothpaste, they're going to have to rinse a lot. You only need a pea-size amount of toothpaste. That's not what we use at home, though. We use this whole stripe, right? And that's because marketing showed us that the toothpaste people want us to use this whole, and they want us to do this whole, little, you watch the toothpaste commercials, right? Watch the ads. It's got this whole big, wavy thing, right? Why? That's right. It's a sales gimmick. If they could convince you that you need a lot of toothpaste, you'll end up buying more of their toothpaste, right? But if you read the instructions, it'll say a pea-size amount. So the instructions are telling you to use a pea-size amount, but their marketing is showing you something different. But we tend to go with what we see, that visualization. When we're brushing somebody else's teeth, less is more here, people. A pea-size amount. That way they're not rinsing until the cows come home. Once or twice for rinsing is enough. All right. Once they rinse, they have to have a place to spit. So give them a basin so that they can spit. And then when they're all done, make sure that their face is dried off. Guys, this is the number one checkpoint that's missed on the test. People forget to dry the patient's mouth. And it's funny because during the test, if you're a patient, you have to sit there and drip. Like you're immediately going to want to do this, right? Get that off of my face. You've got to sit there and drip because they're waiting to see, are they going to catch that?
You can't help your fellow.
You cannot help. You cannot help. You cannot. In fact, if you do, not only will you fail, but they'll fail. Yeah, both parties would fail. Even if they didn't ask you to help them, both parties fail. Yeah. So don't forget to dry. And then you're just going to do your closing. Put your dirty stuff in dirty linen, clean your basin, put everything away, make sure the environment's neat and clean, and do your closing. That's it. Nothing to this one. This is like the easiest skill because we already know what to do here. But boy, is it awkward to be a patient for. It is awkward. It's not the most awkward. It's not the, this actually comes in on 3 on our awkward scale. Number 2 is pericare. Yeah, there is a skill that is more awkward than pericare. We'll get to that next week. I know everybody's going, wait, you can't get more awkward than that. Yes, you can. From a patient standpoint, you actually can. All right, question I get all the time, do I have to brush everybody's teeth? No. We're only going to brush the teeth of the people that can't do it themselves. If they can, they will. So we're going to follow our care plan. Care plan tells us who we're going to brush. Good? This care plan is only for that person. It doesn't apply to anybody else. Just this one. All right, Jake. Mouth care, please.
Hello.
Good morning, Mr. Jones. How are you?
I'm well. How are you?
Fantastic. I'd like to perform mouth care on you. Is that okay?
Yes.
I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I'm going to use a paper towel as a barrier to put the head of the bed up, since my hands are clean and the bed controller is not. Once we get the patient to an upright sitting position, I can throw the barrier away and then adjust the pillow so it's a little more behind his back rather than his head. There we go. Good?
Yes.
Okay, let me go get the rest of my supplies and I'll be right back. I'll gather my supplies. We're going to start with a barrier, and that gives us a clean place to place our clean supplies. So we're going to open the barrier up. And I also need a towel. We're going to get an emesis basin, a toothbrush, toothpaste, and a cup of water. And we also need a pair of gloves. I'm going to get my toothbrush prepared by wetting it and putting toothpaste on, and then storing it in the emesis basin until I'm ready to use it. Mr. Jones, can I place this towel over your chest?
Yes, please.
Thank you. This is just going to help keep your clothing clean. I'll put my gloves on. And now we're ready to brush your teeth. I'm going to brush the top, the bottom, the front, the back, and your tongue. So can you open wide for me? I'll start in the back, on the top, both sides. And then the bottom, both sides, the front, both top and bottom. And can you bring your teeth together? Thank you very much. And then stick your tongue out. Thank you. I'll set this aside, and now we can rinse. Go ahead and take a sip. Another sip?
Yes, please.
Okay. I'll pour the water in the emesis basin, set them on the table, and then I'll take this towel away and put it in dirty linen. I'm going to go clean my basin. We'll clean the emesis basin by dumping the saliva into the sink, rinsing the basin, setting it down, and disinfecting per facility policy. Then we'll take a paper towel to pick it up, a paper towel to dry the inside. We'll throw that paper towel away. Paper towel to dry the outside, throw that paper towel away, and one for the drawer. Now I can return the basin to storage, putting the toothpaste in the basin and using a paper towel to open the drawer to store the basin back in it. We'll close the drawer with a paper towel and then throw those paper towels away. All of these disposables will be disposed of. I'm going to go throw this away. I'll be right back.
Okay.
Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Bed is in the low position. Your environment is clean. Let me get your call light for you. Would you like a magazine before I go?
No, thank you.
Okay. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come in and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Lights on. All right, any questions? Any questions? Yes. 1 second. Go
Are
ahead.
there any skills where the bed is not going to be in the low position?
You can raise the bed up for any skill that you do. It will always be in the low position to start.
Okay.
But you can raise the bed up to a comfortable working height for any skill that you want to do.
Okay.
But at the end of the skill, you've got to remember to lower it. You don't have to. You can if you want to, but I asked if he was comfortable. He said yes, that's all I had to address. Okay. Any others? Good? Ready to move on? Oh, go ahead.
What about gag reflex? You know, when you brush the tongue, do you ask them, or do they tell you? You say you have, because brushing the tongue is always.
You just want to brush the tip of the tongue. You don't want to go too far back because you will activate the gag reflex. Yeah, so just the tip of the tongue. Good? Okay. Oops. All right, so the next skill we're going to learn, or the last skill today, is respirations. This is breathing. You guys remember pulse? This looks just like pulse. This video looks identical. to pulse. But instead of counting the thumps that we feel under the fingers, what we're going to count is the chest rise and fall. We're counting their breathing. Respirations is breathing. So just like with pulse, we were standing on the side of the bed and staring at the patient for 1 full minute quietly. Respirations, we're standing on the side of the bed, staring at the patient for 1 full minute quietly. And in fact, I'm going to be holding the patient's wrist just like I did for pulse, but I didn't find the pulse. And the reason for that is if I just stand over a patient, how creepy is that? Yeah, I'm staring at somebody's chest quietly for 1 full minute. It's creepy. It feels much more natural for the patient if I'm standing there like this. I do not have her. She doesn't even have a pulse, guys. I don't have her pulse. Okay. I'm holding her hand, but she is going to focus here, not here. If she's aware of her breathing, it'll alter her breathing. It just will. She'll either breathe faster or she'll stop breathing. She'll hold her breath because now she's aware of it. And if I actually ask you guys to start thinking about your breathing, you will all change your breathing patterns. And then it takes you a long time to try to get away from thinking about your breathing, right? Breathing is autonomic. So when we are measuring respirations, we don't want our patients to know that we're measuring their breathing. We're actually going to make it seem like we're measuring their pulse, but we are going to count the breathing. Make sense? So we're going to kind of misdirect them a little bit. Now, I know that we have to tell our patients what we're doing in order to get consent. I mean, that's important. So for this skill, I'm not going to say, knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to measure your breathing, or I'm here to take your respirations. I'm not going to say that. I'm going to say, hi, Ms. Jones. How are you today? Good morning. My name is Patty. I'm your CNA today, and I need to get your vital signs. Is that okay? Now, respirations is part of vital signs. I'm not lying to the patient, but I'm not being overly specific either in a way that would cause an error in my reading. Does that make sense? Everybody good with that?
How do you see their chest rising with the gown and the sheet?
So you can see it, okay? It's actually easier to measure somebody's respirations when they're laying down versus when they're standing or sitting. Because when we're standing or sitting, our upper chest is going to do most of the breathing. When we're laying down, it actually moves a little bit lower. We breathe from this area. So you can actually see it go up and down much more effectively when they're laying down, which is why for the test, they have the patient laying down. Easiest possible scenario. But there's something we can do that can actually make it easier for you to see, and we're going to do that in just a few minutes. It's a trick that we can use that we're allowed to use on the test. Okay, I'm going to show you that in just a second. All right, so we already know all the principles involved here. We're going to follow our care plan. We're going to do our opening. We'll evaluate if we need gloves. I am touching the patient. So she's got an incision on this hand. Do I need gloves? Yes. Okay. So we evaluate if we need gloves, and we're going to do the closing. So at the bottom of the page, you can see all the test-specific information. Somebody with your level of experience should be able to do this in 5 minutes or less. It's a live person because we need a breather. She doesn't breathe. That person will be in bed. And this is a documentation skill. You have to write down what you measure. You can be off by 2 breaths in either direction. Normal is between 12 and 20. So let me give you an example. So if normal is between 12 and 20, and the evaluator gets 16, if you got 14, 15, 16, 17, or 18, you're accurate. 2 breaths in either direction. Guys, that is a huge margin of error. It's like half of the range. All right. So our step-by-step instructions are on page 55, care plan at top, supplies at the bottom. Let's look at the care plan. Care plan says the patient will be lying in bed for the skill, count the patient's respirations for 1 full minute, and record your readings. How long are we counting for? 1 full minute. We know everything we need to know except our skill specific. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. But when it comes to the skill specific here, we don't want to tell them I'm counting your respirations. We don't want to tell them how to breathe. I don't want to say, okay, just breathe deep and even for me. I don't want to say in and out, deep breath. I don't even want to mention breathing. So be really careful with this. All you're going to say is, I'm here to take your vital signs. In and out is counted as 1 cycle. So that whole thing was 1. It doesn't matter whether you say 1 on the inhale or 1 on the exhale. The whole thing counts as 1. Okay. So if you start counting, if you pick a number on the clock and we say start and the patient's exhaling, it counts. All right. We're going to count for 1 whole minute, or as detailed on our care plan. Our care plan says 1 minute. We'll count for 1 minute. That means that wherever that second hand started, when we said start, it's going to go all the way back around. And when it hits that point again, we're going to say stop, because those evaluators have to count too. And they have to count for the same amount of time you do. Now, if that care plan does not specify 1 full minute, you can do the whole 15 seconds and multiply by 4. And as long as your patient isn't in any distress at all, if they're just breathing normally like all of you guys are, nobody in here is in any distress, 15 seconds and multiply by 4 is perfectly okay. It just kind of gives us a baseline. You're in normal limits. Everything is fine. But if your patient's breathing like this, that is not a 15-second count. We need a full minute there because it's just way off of base. All right, we're going to record on the documentation form that the evaluator gives us at the beginning of the skill. And if you want to see what the documentation forms look like, go to page 168 and 169 in your book. Those are the documentation forms. So let's talk about our cheat. Hey, Jake, can you come move her out of bed, please?
Ow.
Oh, you all right?
Yeah, that's right. Just a hip.
Just put her over there on the floor for now. You got 2, it's fine. Oh, she can be Julie. Good job. Thank you. I need a volunteer. Breathe. All you got to do is breathe. Can you come? Okay. Come lay down on the bed for me. Just lay down, put your feet up. Yep. Shoes, lay all the way down. Relax. Take a nap, actually. Can you put your arms at your sides for me? Okay. So I'm just going to move your sweatshirt for just a second. Now, she's got a big sweatshirt on, so it makes it a little bit harder to see, but you guys can kind of follow along. So if you look at her tummy, okay, now she's going to be very self-conscious because we're all looking at her tummy. I get it. But if you look at her tummy, you can see it's going up and down. You guys see that? It's probably kind of hard to see from far away, though, isn't it? There's a trick that you can use to make respirations a whole lot easier to see, and that's by using an alcohol pad. If you put an alcohol pad on the tummy, now watch her breathe. It becomes much more visible. Do you guys see that? It's easier to see. So that's psychology. That's all I'm using here is psychology. I'm using a contrasting color because it's a different color than what she's wearing, because motion in a contrasting color is designed to attract your attention. This is what kept us safe from the saber-toothed tigers when they were racing through the jungle, right? That flash of color that's moving draws your attention. That's what I'm using here. So you can use this for the test. You can put an alcohol pad on their tummy for the test, no problem. No problem at all. In fact, it makes it easier for those evaluators to stay on the other side of the room, which is exactly where we want them. Okay.
Just an alcohol pad.
So, okay, you can use a lot of things, right? Basically anything that's a contrasting color, I can put on her and make it more visible. But here's the problem. If I put anything else, if I put my pen on her tummy, that's weird. She's probably going to ask, why is that there? What are you using that for? If I put something heavy on her tummy, it might affect her ability to breathe effectively, which would slow down her respiration rate. The reason that I use an alcohol pad is because they're mystical, magical, and medical. Alcohol pads, if I put it on her tummy, she's less likely to ask why, because she assumes I'm going to need it for something later, like disinfecting my hands. If she does ask why, I give her a non-committal, non-answer. I need that for later. And you know what she's going to say? Okay. Alcohol pads give us a lot of leniency because people are comfortable with them, used to seeing them. Okay, it gives us some leniency. Make sense? Good. Thank you. Thank you.
Will that be in the supply area?
It'll be
or
in the drawer
in the drawer.
or on top of
Don't
the.
bring our own.
Nope.
We can't bring anything.
Nope. So the evaluators will show you. They'll either be in a little square on top, or they'll be in the drawer, usually in the drawer. Okay. So make sense? Okay, there's a whole lesson on documentation principles on page 48 that you will want to read this weekend. All right, so we're going to watch this video on respirations. Again, just like pulse. Do you remember with pulse, I had on the screen, the words got bigger and smaller so you could count along with? I'm going to do the same thing with respirations so you can count along with my, what you're seeing on the screen. And I made it pretty obvious with the video angles. You can actually see him breathing. Okay. Try to count with the video and see if you get the same number that I get or within 2 breaths of that number. All right. Okay, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If
Thank
you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Okay. Questions?
I have 2 questions. First, if there are 2 evaluators, are you going to have to document it twice?
No, because this one doesn't require that they are feeling anything, so everybody can count at the same time. So
Okay.
once is enough.
And then for the second question, if you're watching their respiration, is there any way to know when the full minute has passed?
You're just going to have to glance up occasionally
Okay.
to look. And remember that in and out takes a long time, so you can certainly glance up in the middle of in and out and still be okay. All right, good? Good. Any other questions? Okay. All right, so Jake handed out the test registration packets. We're going to go through them all together. This is a much more extensive process than you think it is. Okay, it's not just a matter of filling out your demographic information and paying a fee and you're done. There's a lot of steps to this process because it is a credential that you're getting. So we're going to go through all of this. I'm going to go through it relatively quickly because we only have about 34 minutes. It sounds like it's not quick, but it is. I want you to know where to find this information, though. If you go to my main website, 4YourCNA.com, along the top, you're going to see menus. You'll see CNA training, which has everything to do with training. You'll see testing, which has, you'll see testing, which has everything to do with testing. And then you'll see after certification, which is going to be your renewal process, continuing education, employment, that type of thing. So right now we're talking about testing. So this is going to be under the testing menu. If you open it up, down here, you'll see test registration instructions. That's where you want to be. When you click on this, it's going to take you to a page that has a video that walks you through the entire test registration process. Everything that we're going to talk about in class is on that video. It is also on flcnatraining.com, which is where our live stream is, under class 4, which is today. Today is class 4. So I put that video right there for you to see it there as well. So you've got a couple places that you can see that video. So test registration actually has 4 steps to it. You guys have this. These are the 4 steps. This is my older, I just made this. You guys are the first class to get this. This was the older version that I used to give out, but it was very confusing for people because there's lots of words. So I made it very colorful and just 1, 2, 3, 4. These are the 4 steps. So step 1 is going to be getting your background check. This is a question I get asked a lot, and I'm going to answer it very simply. Everybody needs a background check. I don't care how many you have on file. I don't care if you're currently working in healthcare. I checked with the Board of Nursing. If you go to the Board of Nursing's website under their FAQs, it's very clear that every new applicant needs a new background check. Period. Okay. So they used to be able to take background checks from, if you're working in medical or whatever, you have to have a new background check. Okay. So step one is the background check. So let's start there. If you turn this paper over, I have instructions on how to do the background check. So if you go to Prometric's website, they're going to give you information on all of this. If you go to Prometric's website, which is prometric.com/exams/nursaid-FL, and oh, I don't have that on here. I'll have to put that on here. You can take a screenshot of this. This is your website, prometric.com/exams/nursaid-FL. When you go to Prometric's website, you're going to see these 4 headings. If you click on each one, it opens it up into like an accordion thing. And application process is where we are going to be. Oh, sorry. I'm sorry. Let me go back. I'll go quicker or slower. You're welcome. It's also, guys, this registration packet that Jake handed you, it's at the very, very top.
Oh, I thought you said it wasn't on there.
It's not on here. I thought I put it on here for you, but it's not on there.
Okay.
Yeah, the old one had it, but not the new one. Okay, so if you open up application process right here, you're going to see 2 links. One is an online form and one is the paper form. The paper is what we handed out. This is the paper application. Now, it's much quicker if you apply online, way quicker, by like 2 weeks quicker. So the online application is this. It's this exact form. You just transfer everything online. So we're going to fill this out in class together so I can make sure you get the right things in the right places and that you're not making any mistakes. But then you can take this and use it as a template to fill out the online form if you want to go that way. If you just want to mail this in and you're not in any hurry to test, you can do that too. All right. So the first thing we have to do is get our level 2 background check done, and then we're going to apply for the test. That's the order this has to happen. And it's there's a very good reason for this. When you apply for the test, the very first thing they do, when you apply for the test with Prometric, you send your application in either online or by mail, doesn't matter. The very first thing Prometric does is it goes to the clearinghouse to pull your background check. If you apply to Prometric, they go to the clearinghouse and there is no background check, the whole thing just stops. It just stops. Your application is now dead in the water until they get a background check. And that can take some time to do. So you don't want to stop this process. You want it to go very smooth. So background check first. That puts you into the clearinghouse. Apply for the test. They go get your background check. When Prometric gets your background check, they create what they call a package. That package is your application, your fee, and your background check. They put it all together in a package and they send it over to the Board of Nursing. So there's a whole nother player in this. It's not just you and Prometric. There's a third person involved, the Board of Nursing. Now, the Board of Nursing's job is to look at your application and your background check and make sure that you are safe to take care of grandma in her house unsupervised. That is their job. They are tasked with protecting vulnerable populations from you. So they're going to look at your background check. And if they see anything that makes them think, I don't know if this person's really safe, they're going to contact you. So let's say that you've got one shoplifting charge from when you were 17 years old and you're now 34. You've never been in trouble since. You took care of everything when you were 17. Everything is fine now. They're going to look at that and go, yeah, that person was young and dumb and made a bad mistake. They learned from it. They're okay. If you've got 17 shoplifting charges and the last one was last month, we don't want you in grandma's house around her medications and her checkbook and her candlesticks, right? They're going to look at those two things completely differently. Everybody was young and dumb. Not everybody got caught, but everybody was young and dumb. We've all made errors in judgment. They don't hold that against you. But if you were young and dumb and didn't grow out of it, and you kept reoffending, that's going to be a problem. Or if your offenses were serious, that resulted in the potential for harm of another human, they're going to look at that a little different. So if you have vehicular manslaughter, that's not a shoplifting charge, right? Do you guys understand the difference there? They look at the amount of offenses, how long it's been since the offense, when what age you were when you offended, and the seriousness of the offense. So some of you are going to come up to me and say, yeah, I had one DUI 6 years ago. Do you think it's going to affect me? I don't know. I can't make that determination because this is a human that is judging you, not a computer. This is a human. They are looking at your situation and your situation alone to figure out if you are a good fit. Now, if they have a concern, they're going to reach out to you and they're going to say, hey, can you tell me a little bit more? Send me some information on this. Show me that you're a good fit. Now, if they still have questions after that, they will invite you to come to a board of nursing hearing where you actually get to stand up in front of the people that are judging you and say, hey, yeah, I made some really bad mistakes. I know I was on a very dark path. I learned from my mistakes. I've now been 5 years sober. I'm in good shape. I really want to give back to the community. This is a step in my recovery. I'm going to meetings. Whatever it is, you sell yourself, you make your case. And then they will make a determination whether you're eligible or not. Make sense? Okay. So do you see that that's a pretty big process? That's not simple. We do our background check, we apply for the test, and then we wait. That's the part that you guys get all mixed up in. You have to wait because there's so much going on over here that you can't see and you don't know is happening. You're just waiting. And this can take 2 or 3 weeks of waiting where you're not hearing anything. And then if you're cleared for testing, okay, if you're cleared, Board of Nursing reviews your package. If you're cleared, they're going to send an authorization to Prometric. They're going to say, hey, this person, okay to test. Cool. If you're not cleared, they're going to send you a letter. Tell me more. But either way, you're going to hear something. So if you don't have any criminal history, it's pretty straightforward. You apply, you do your background check, apply for the test. About 2 weeks or so, you're going to get a notification from Prometric that says that you are approved for testing. So when Prometric gets the approval from the Board of Nursing, they send you a letter that says you've been approved. You still don't have a test date yet. They just send you an email that says you've been approved. So you know where you are in the process. It takes another 3 to 5 days roughly before they send you an email with your test date. And that's because when Prometric is notified that you're approved, they have to go to the testing centers and say, hey, when's your next test date? When do you have an opening for this person? And that takes some time to coordinate. So you get an email that notifies you of the approval, and then you're going to get another email that notifies you of your test date.
And your test date,
You have no say. You get a test date. Now, if that date doesn't work for you, you have transportation issues, childcare issues, school, whatever, you can call Prometric up and you can say, hey, that date does not work for me. And while they're on the phone with you, they'll work out a mutually a mutual date that works. Okay. But your first date, nah, you don't get to pick. They're just going to assign one. If you can make that date, it's best. But if you can't, they will work with you. Now, this notification that you get, it's called an authorization to test, ATT letter. This notification, if you can print it off, that's what you would take to the testing center. If you don't have printer capability, it's no problem. You don't have to take it with you. But I usually recommend that you do take a physical copy if you can, because if there's an issue at the testing center, and sometimes there is, you might be holding an authorization to test that says that you're okay to test on the 13th. You go on the 13th, bless you, and they don't have you down. If you've got that letter in your hand and you can show it to them, they'll go back and fight for you and you'll be able to test that day. If you don't have that letter, they're going to tell you, go home and call, and they'll have to reschedule. So it is in your benefit to take, bless you, proof of that test date with you, if you can.
You get to at least choose where you're testing.
Yes, we are going to choose our testing center. Yes. Yes. So everybody understand this whole process? This takes a little bit of time.
Are there a certain amount of days you need to wait after you get your background check?
We're going to talk about that now.
I'm sorry.
Yeah, no, good question. Good question. You're right on track.
When they notify you of your date, is there usually a certain, like, what's the word? I don't know. A general
They
like,
test.
amount of time after you get the time?
Okay, so they test 7 days a week, even on anything but a major holiday. Okay, so they test on Mother's Day, Father's Day, Valentine's Day, Veterans Day. They don't test on Christmas, New Year's, Thanksgiving, Memorial Day, Labor Day, or 4th of July. That's the only times they're closed. So because they test 7 days a week, they get through the candidates pretty quickly. Okay, so when you get your authorization to test, they're saying, okay, you're approved. Your next email will have your test date. The next email comes usually about 3 days later. You'll be testing usually about 5 to 7 days from that point. It's pretty quick. So if you get a letter that says you're testing on the 13th and you can't make it on the 13th, don't wait until the 11th to let them know. When you get that notification, if you know you can't make it on that date, you got to get on the phone with them right then so that they can slide somebody else into that spot. Otherwise, if you drop that spot and it's too soon to fill it, they're now out that money, and they don't like being out money.
Is there a certain amount of time from the graduation of this class to testing that you have?
The class and testing are not tied together at all because you guys are all challenging. Yep, it's not tied at all, not tied to training at all. All right, so let's talk about background check. This gets very confusing. These are the instructions for the background check. If you follow this step by step, it makes it pretty easy. I actually I contacted them. I actually got a hold of a senior account manager, and I said, your process is too difficult. It's too confusing. There's too many options here. I don't know what to tell my students to pick. And so they actually sent me a list of steps. This is what we want your students to do. So I made it pretty for you. Okay, just follow it. It was getting all kinds of confusing. Now, I will tell you that some students have gone to the sheriff's department to get their background check. The students that went to the sheriff's department, I had a class back in December. They all decided they were going to go sheriff's because it was way cheaper. It's like right around Christmas time. They don't have any money. So they didn't test until like what, April, May, Jake? It was like months. So I don't recommend that. It might be a little bit cheaper, but the process is just not streamlined. This is a streamlined process. If you use, and I don't get a kickback, I'm not affiliated with them in any way. I'm just trying to give you information to streamline your process. Okay. You can go on to Prometric's website under candidate resources. It'll take you to a website that has every fingerprint testing vendor approved to do this in Florida. It doesn't mean that they're all equal. I know this one is quick. Deontis, or it used to be Deontis, it's now DTIS. This uses the UPS store at Barclay. They also have one in Lecanto. Okay. But if you go to this website, When you go there, you're going to want to create an account. And you can see right here, you want to create an account. You need an account with them to register for background checks. So you want to create an account. That you have to make one of those super secret passwords with letters and numbers and capitals and symbols and all the things we can never remember, just super secret password. That's the hardest part of this. Once you do that, they're going to have you verify your email. So they'll send a code to your email. You'll have to put in there that two-factor authentication. This is what they actually sent me with instructions. You're going to go, I don't have them. Oh, I don't have them up here. Okay. I don't have these. So once you have, I'm in the middle of updating my slides, guys. I've created slides. I just don't have them in here yet. When you create your account, you're going to go back to the website, once you type in your code for that two-factor authentication. When you're back on the website, you want to click on Florida Services. And that's what it says here. Click on Florida Services. And that's gotten really confusing for students because it doesn't say anything about CNA testing. It's, what do I click here? So Florida Services is what you want. And then the next code or the next area, you want to licensing. You want to choose licensing. And it's going to ask you for an ORI number. I've put that here for you. This ORI number is what routes your background check to the right agency for CNA testing. If you don't use that code, I have no idea where your background check is going to go. So you need that code. When you go get your background check done, they're going to take a photo, fingerprints, and signature, and then they send that off electronically. They're not going to give you anything to send anywhere. You don't submit anything. You just go to the appointment. That's it. That's all you have to do. 24 hours later, you can register for the test. It's that quick. That's why I like this, because the process is very streamlined, very seamless. Right. So when you go to DTIS, you're going to click on Florida Services. You're going to put in your ORI number and click licensing. This will tell you exactly how to do it. And then when you get to the end, it's going to ask you to choose a service location. So you're going to put in your zip code, and it's going to pull up all the locations nearest to you. And you'll pick the one you want to go do your background check at. Okay. Okay. Northcliffe and Mariner. Okay. 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 All right. This is a little bit cheaper. If you register online, it's like $78. Okay. So it's a little bit cheaper. All right. So now that we've got our background check done, yay, we're good. 24 hours later, we can do the application for testing. So that's what this is. This is the paper application. So let's go through this really quickly. But I want to bring this to your attention. This is on Prometric's website. If you don't hear anything else I say about this, listen to this. Prometric's website tells you if it has been more than 5 days since you submitted your application and you haven't heard anything, you need to contact them. If it's been more than 5 days, you need to contact them. Super important. Because if something happened to your application, if the server glitched, if it didn't save your application, and you're sitting around waiting, nothing is happening here, and you're getting further and further behind. So they're telling you if it's been more than 5 days since you submitted an application and you haven't gotten a confirmation, you need to contact them. But here's the problem. When you pick up the phone and you call Prometric, the person that answers the phone, their whole job is to get you off the phone. That is their entire job. They have no information about your account and they couldn't care less. They want you to hang up. So they're going to tell you it can take up to 90 days. It can take up to 6 months. They pull numbers out of the air. It can take up to whatever. Don't worry about it. Call us back in a couple of months. No, you're going to say the website for Prometric told me to call, I want a supervisor. Now, the supervisor can access your actual information. You've got to get past that receptionist. Okay? I hate to say that. I wish I could tell you that Prometric was customer friendly. They're not. So I got to tell you how to work around them.
Should we do our fingerprints now, or should we wait till graduation?
No, you should do your fingerprints now. If you've got the money and the time, you should do it now. If you do your fingerprints this weekend and you register for the test this weekend, you should be testing a week or two after graduation, which is perfect timing. If you wait until you graduate, well, now there's a gap in time where things can be forgotten, or I'll practice later and then you never do because life gets in the way. So that's why we do this on class 4, because I really want you to register in this time frame if you can. I know some of you have to wait on paychecks or vacations or whatever, but if possible, this is the right time to do it. Okay, so I told you that this is the same as the online application. So if you go to the online application and click it, this is what you're going to see. It's going to look just like this with 2 exceptions. We're going to get to that in just a minute. There's 2 things that are on the online application that are different than the paper application that you have in front of you. We're not going to fill this whole thing out together. You've got instructions here. I've also given you a video where I actually do it on the screen in front of you. We're not going to go through all of this, but I do want to highlight a few things that are problematic for students. So the first thing that we want to talk about is this. Please make sure that the name that you put on this registration is the name that is on your photo ID. If there's a hyphen, you need a hyphen. If there's no hyphen, there's no hyphen. It's got to match. Okay? If you use 2 last names, use 2 last names. It's got to match. The next thing is if you need ADA accommodations, that's disability accommodations, there's a whole packet that you would have to fill out. This will give you information on that. Down here at the bottom of page 1, you're going to see your demographic information. We're not going to fill that out in class together. You can do that on your own. You know your name, your address, you know your phone number, you know all of your demographic information. We're not doing that together in class, but let's go down here to the bottom of page 2. This is where it gets really tricky. When you're looking at the bottom of page 2, there's some questions there, and it says criminal and Medicaid, Medicare fraud questions. If you have a felony in your background, you need to see me after class. If you have no felonies in your background, you're going to check no for number 1 and no for number 2. You're going to leave the A, B, C, D, E's blank. Just no. Because question 1 and 2 have to do with felonies. If you have no felonies, they don't apply to you. Question 1 and 2, no felonies, don't apply to you. Check no. If you go to the next page, questions 3, 4, and 5, this is asking, now this is very specific, guys, very specific. If you have worked for a medical provider, like a doctor or a pain clinic or something like that, that participated in Medicaid or Medicare fraud, duped the government out of millions of dollars. And yes, we have had several in this county that got caught doing this. That's why I have to go over this. If you worked for their office while Medicare and Medicaid fraud was going on, and you were found guilty of participating in Medicare or Medicaid fraud, and you were prosecuted for that, you would have been put on a list that keeps you from working in medicine ever again, because you know how to defraud the government. We don't want you around government defrauding information. Make sense? If that scenario applied to you, you need to read 3, 4, and 5 and answer them appropriately. If that scenario does not apply to you, it's no for 3, 4, and 5. Good. Yeah, we just had a doctor 3 months ago, that was just caught with us. Happens more than you think. All right, So now we're moving down to disciplinary history. This is pretty self-explanatory. If you've ever had a medical certification in Florida or any other state, and they took discipline against you, you have to declare it here. If you've never had a medical certification, the answer is no all the way down. Then we're going to go to the bottom of the page, criminal history. You read an answer. That's between you and your higher power. But be honest. Be honest. If you say you have no criminal history and one shows up, you have lied on your application, you are not going to get certified. That's an ethics problem. So if the answer is maybe, it's yes. Much better to check yes and have nothing show up than check no and it look like you're lying. This usually happens with juvie records because you do pretrial intervention. We don't like to put things on your permanent record, and nobody knows how to, declare pretrial intervention because it didn't really go on your record, but you're not really sure. That's when you get into gray areas. Check yes. All right. Page 4, I am not allowed to help you with. Legally, I cannot offer any guidance on this at all. Read the questions and answer them. I'm skipping page 4. I'm not allowed to help you. It's all self-reported. Your Social Security number does go on the bottom of the page, though. Now, if we go to the top of page 5, I've already done this for you. This is why I hand these out. I've already done this for you. You are all going to check off E3 Challenger. It's already checked off for you. But when you go onto the online application, make sure you choose E3 Challenger. You guys are all challenging. 89% of all CNA applicants in Florida challenge. Nobody goes through a program anymore. It's all challenging. But you got to make sure you're checking the right box. The section below, I've got an X in, and that's because you only fill that out if you checked E1 or E2. We didn't check E1 or E2. We checked E3. This does not apply to us. That's why I have an X on it. Coming down here, it says test site information, and this is where you asked, can I choose my test site? Yes. So at the back of this packet, the application packet, you have, we do not have. Okay. Yeah. Darn it. Okay. So some of you have. Yeah, it's not.
It's the new packet is different.
Yeah, it should have been in here though. Okay. All right, I will have, I'll print them off for you. I will email them to you. But there is a list of testing centers. I'll just send you yeah, it looks like that. A list of testing centers in the state. Pick the one that's closest to you. We're in Central Florida. There's 3 in Tampa. You can pick any of those. Generally, our students go to a Gillis on Waters Avenue because it's the closest to us. It's straight down the parkway before you get to the airport. So it's the quickest and easiest one for us to get to. There's also one in Ocala if you're up in Citrus County, but you can look through this list and find the testing center closest to you. They don't care where you test. All Florida testing is the same. It doesn't matter if you're testing in Miami or Tallahassee, the test is exactly the same. So if you want to get on a cruise ship and you want an excuse, go test in Miami and then jump on a cruise ship and, drink your cares away. You get to choose where you want to test. But for us, our closest one is a Gillis. Same day. Same day. So that's the next section that we're going to get to. When we're talking about test site information, you're going to choose the one that you want to go to. And on the paper that I gave you, you have a test site code. If you're mailing in your application, you want to write the code here. Remember I said there's 2 things that are different with the online? The online, you don't have the code. It's a drop-down box. You're just going to choose the testing center you want to go to. in the drop-down box. So on the paper application, you actually write the code in here. You're going to choose the test that you want to take. For most of us, 99% of us, where are we? We are going to choose the second option. It says clinical skills and written, I'm sorry, the first option, clinical skills and written both in English. But if English is not your first language or you have a reading deficiency, you might want the computer to read the test questions to you. Attention deficit, that type of thing. You might want the computer to read those questions to you. If that's the case, you're going to click the second option. Second option says oral. It just has the computer reading this test questions to you. The cost is $155 no matter what you're choosing. And then if we go, let's go here. And if we go to page 6, you're going to see a box at the top that asks, have you received and read the privacy policy? Those are the 2 pages that are attached to the back of your forms. Those pages are how the they're going to use your information to clear you for testing. You've got to check yes that says you received those pages. That's why I hand them out. You can now check yes. Whether you read them or not, that's up to you. Down here is your affidavit. You're going to read, sign, and date. If you're doing this online, your signature is going to be electronic. If you're doing this by paper, you're actually going to sign in there. Last page is for payment. Now, I told you there were 2 changes between the paper and the electronic. The first was that test site code. The second, if you're doing this online, at the very bottom is going to be a box, and it's going to ask you how you plan on providing supporting documentation. That's all it says. How do you plan on providing supporting documentation? Which, what does that even mean? If they contact you and say, hey, tell me more about your situation, how are you planning on sending that information? By mail or by fax? Check a box. I don't care which box you check. Check a box. Even if this doesn't apply to you, you have to check a box before it allows you to submit your application. So check a box. Any box. Check a box. Because otherwise, it's not going to let you submit. And students call me tearing their hair out. I don't know why I can't submit this. You've got to check one of those boxes. And then it'll have you put your payment information in as well, right on that screen. At the bottom of the online application is going to be 2 buttons. One says save, one says submit. If you hit save, whatever payment information you put in goes away. Does not save payment information. So you have to enter it again before you hit submit. Save does not say, it just saves everything else, but not your payment stuff. Submit submits everything. Okay, good? Questions? Okay. Any questions on today? You can go back and watch this presentation. But if you go to flcnatraining.com, under class 4, watch the test registration video. It'll be a little bit more clear. All right, have a fantastic weekend. I will see you on Monday. Those of you joining us online, thank you so much for hanging in there. Monday, I will not have Jake, so bear with me. Your questions may take a little bit of time to get answered because I do not have an assistant for Monday. So please bear with me. We'll do the best we can. We'll muddle through it together. All right. Until next time, happy caregiving. Bye.
We do have homework.